Bore da chi gyd, a croeso i'r gwrth iechyd Prifysgol Aneurin Bevan. Good morning, everybody, and welcome to today's meeting of the board. A number of people will be attending as our guests, and I'd like to welcome those who are attending on Teams, members of the public, and we hope that you find the meeting's contents helpful to your understanding of what we're trying to achieve in Aneurin Bevan. Today's meeting will be recorded and published to the Health Board's website for viewing following conclusion of the meeting. Now, there is a national problem with Teams today, so it might be that unfortunately Teams will crash, and it will be something that we probably alone cannot solve. But we would hope that that doesn't occur, because we would wish people to be able to see our discussions and debate. A number of guests will come. I'm afraid Gemma Morgan is not very well, so she won't be here to present her report. For the midwifery-led services item, we will be joined by Claire Lippitz, the Divisional Director, Jane Beasley, the Head of Midwifery, and Linda Alexander, the Deputy Director of Nursing, to support the presentation of the papers that you received and to answer any questions. I'd like to welcome Errol Flowell, who is a consultant in public health, who is representing public health today in the absence of our new Director of Public Health, who will be joining us in the coming months. Are there any apologies for others? I don't think so. Okay. Any declarations of interest for noting on any of the agenda items? Okay, thank you. Could we move then to the draft minutes of the Health Board meeting held on the 30th of November for approval? Are they a correct record?
Yes.
Yeah, thank you.
I've got one here.
Right, thank you, Ewan.
It's 30/11/19. I've already mentioned it to Brian. There's a comment in there about the risk tolerances and the 4 risks. My comment was more about the other risks.
Okay. So we've got a form of words that's satisfactory. Right. Thank you, Ewan. So with that amendment, we adopt the minutes. We also have a summary of the board business held in committee on the 30th of November and the 14th of December. Any comments, please, about that? True record of what we discussed. Thank you. Let's adopt those. And could we move then to the report on the sealed documents and chair's actions? Rani.
Okay, so this paper provides the board of the use of chair's action and the application of the Health Board's policy for the period 15th November 2022 to 10th January 2023. During this time, there has been one document that's required sealing, and that was in respect of the transfer of deeds, and is outlined within the paper. And in addition, there have been 4 matters agreed by the use of chair's action, and again, the detail of which is set out within the paper. The board is therefore asked to ratify the use of chair's action and application of the common seal.
Yes, agreed.
Agreed. Any further comments about that? Okay. Thank you very much. Could we move to the board action log review? We have them in front of us. Rani, please.
Yeah, thanks, Chair. So the action log includes 3 actions from previous meetings, 2 of which have been allocated to committees of the board and are scheduled within respective work plans to take forward. And there is 1 action in relation to the implementation of WCCIS in mental health. This summary note is being prepared for the members and will be circulated shortly.
Are we happy that the action now has been concluded and satisfactory? Thank you very much. The report from the chair. Apart from my usual bilaterals with board members, local authority leaders, and the RPB staff, together with a number of visits, which I'm really grateful to the staff for their time and energy. They're all continuing to work extremely hard in very difficult circumstances. And I'm really grateful to them for their ideas and for sharing their views on what we can do about problems that beset us time to time. I have chaired the peer group of chairs at which we discussed community capacity building in line with the premier priority of the minister. And we sent a letter on social care and what more we felt could be done from chairs and chief executives to the minister, which has been accepted by the minister and which she is acting on, which is really helpful. We've had a discussion, obviously, about public appointments, training and mentoring, and most important of all, the sharing of experience around emergency and urgent care, which obviously was shared with the chief executives as well. There is another meeting of the chairs on Tuesday when that discussion will continue. I've chaired a special meeting of the Regional Partnership Board to look at the Regional Improvement Fund tapering arrangements, which led me to write to the Minister on behalf of the RPB to ask for her to consider the possibility that she might remove the tapering requirement, which would have meant that the statutory bodies, the 6 of us, would have had to have found about £10 million next year, or stop some of the schemes. We didn't feel we were in a position with confidence to do either of those, and therefore we wrote and explained why we would really welcome a cessation of the tapering requirement for a year. The Minister has considered this carefully and has agreed that she will suspend tapering for 1 year. That will allow us the time to thoroughly evaluate the schemes, so we get into a position where we can make reasoned, evidence-based decisions on the future of many of the schemes funded by the RIF. So that was really good, and we're very pleased indeed that she agreed to that. We have also had a further meeting of the Regional Partnership Board in the latter few days this week, at which the winter plan and its success or otherwise was discussed at length. We also considered how we were going to evaluate that winter plan and what we would do next about it. As you know, the statutory duties of the Regional Partnership Board are under consideration by the government, and the consequences for that were discussed. And we did have a number of views from both the third sector and the regional citizens panel discussion, which were very helpful and will guide the agenda for the next meeting of the Regional Partnership Board. I attended also a Regional Partnership Board Chairs meeting with the Minister, where she launched her new proposal called Further Faster, although it might have changed in the week, which is their mission to build an integrated community care service for Wales. This will be further discussed today at a Care Action Consortium meeting, but it does really urge health boards to build up their community-based services, which of course is a primary task in our IMTP and in our strategy. And I will circulate more information to you when I receive it. The Minister called a meeting as well of health board chairs and local authority leaders to discuss the delays in care being transferred to the community services and to social and so that the outcomes of that are being pursued. I also attended a PSB meeting, which performance principles before were discussed further, and we have now received a letter from Public Health Wales and our own Public Health Department about the actions that should be taken to allow us to become an accredited part of the foundation economy. I will circulate that. It only came in yesterday. And I met the Older Persons Commissioner about her work programme for the next year, which she has promised to send us in the next delay, having met a number of the other care to discuss their view. And finally, we appointed the Director of Strategy and Planning, an extremely strong field very, very strong indeed, and we agonised, I think you could say, over making a decision, but we did make a decision, and we think that we will have an incredibly strong planning and development department. And I'm really deeply grateful to the people who took part. I'm very, very grateful to the candidates, and I look forward to working with a first-rate team in all respects in the next few years. That is my report. Do you have any questions? No? There will be a meeting, a special meeting or a seminar of the Regional Partnership Board in the next couple of months to look at what more can we do in respect of further, faster and our winter plan evaluation in a partnership mode. And it'd be helpful, I think, if David has very kindly agreed to share some of the experiences in Surrey about digitally enabled discharge or better maintenance of individuals within the community. At that, together with other colleagues, it's intended to learn from what's happened and worked really well elsewhere. And certainly those of you who sometimes listen to the Today programme will have heard of the success of the South Warwickshire plan, which seems to have been coming on leaps and bounds. So hopefully we'll be able to engage with them and others from Bath and North East Somerset. And it would be helpful, I think, good for all of us to hear and be part of that discussion. So thank you. Okay. The Chief Executive's report.
Thanks, Chair. So just a few updates and reflections since the last board meeting. I think the main issue is worth kind of acknowledging and reporting on is as felt like and been like in terms of how all things have response. As we know, we were very proactively planning for with partners as well, and did a huge amount of work, and also knew that it was going to be a challenging time in terms of the potential scenarios around respiratory viruses in particular. And I think it's fair to say that we've seen a peak within 2 weeks, the week pre-Christmas and the week post-Christmas. We'd obviously had the challenges of Strep A that were leading up to that, and then between Strep A, COVID and flu, we've seen huge peaks and huge challenges and pressures on the services, particularly in those 2 weeks, which put our services under significant pressure because it also affected our staff. So at a time when demand was increasing right across the system, right from people contacting 111 to the point that the system was overwhelmed one day, primary care under huge pressure, and then presenting itself into our acute services, including resuscitation demand and critical care. So right across the whole patch. The teams worked exceptionally hard. It did require staff to work, over and above what they would expect it to. I was speaking to ward managers who kind of did 14-hour shifts on Christmas Eve when they weren't, rostered to work to be able to keep those roads safe and running. And, the reflections from many of the staff who've worked in the NHS for a long time, it probably was the most challenging Christmas period that they've ever worked. And we all know that that is something that's been experienced right across the UK and has been a topical issue with lots of places reporting around. We did just about hold our position and was able to not be in a position where we had to declare business continuity, although we came very close to it on a number of occasions. But I think it is credit to the staff and the way they kind of pulled out all the stops to try to keep the services running in very difficult circumstances. We obviously still under significant pressure, but things are a bit more settled, it's all relative, are more settled than they were during that Christmas period, but we really continue to progress with our winter plans. We had more capacity coming on for January as intended, and we continue to progress with our programme of work. We particularly now got a renewed focus on discharge. Jenny, as the Director of Nursing, has taken on a kind of new executive lead around discharge across the whole system. Again, continuing to work with our partners on that. And I know there's a real new energy around how we optimise discharge for patients. And we've got some workshops this week scheduled to support that, and also continuing to have a renewed focus around the ambulance waits and those long waits we see in the community. And we've got again another follow-up meeting with our system leadership team on tomorrow to look at how we can really try to address that and get that flow through ED so that we can continue those timely offloads. So lots of work going on, continuing to build on the plans we already have to continue to respond to the pressures we continue to see. I think just following on from that, it's important for me to just note that we have put additional response in to be able to manage the impact of industrial action, which has primarily been around the ambulance service. But we've had a number of strike days now, and we've really focused some additional resource to ensure there's timely handover of ambulances whilst they are running with a reduced resource. Just to acknowledge there's more strikes now scheduled for February, some of those including our own staff as well, that we are, you know, proactively planning for to ensure essential services working with. Just so a lot of the next 2 months in particular for us is going to be focusing on next year. Whilst we've got to, you know, keep services and delivering this year's plan, next year is a key, going to be a key challenge for us. We know the financial context is even more challenging than it is this year, and we need to produce an INTP that, you know, recognises that, but also tries to deliver against key priorities. But I do think we will be having to make some really difficult choices, as well as driving, you know, improved efficiency. So we will have more conversations of that scheduled for the next 2 months. But we're spending quite a bit of time as an executive team and with our divisions around. And obviously that's a key topic amongst our chief exec colleagues in terms of how we are going to balance priorities within the financial and workforce constraints that we've got. And then just to kind of finish off on the 2 positive areas. One is working with Jen and others, how else continue to look at how we improve patient experience and communication. And I'm hoping I'm going to be able to bring something into the March board around how we enhance that kind of patient liaison service when where they need support or they need further advice and be much more proactive in that space. So we're doing some work on that. And then finally, we continue to focus as an executive team and with our colleagues around how we engage and support the workforce. We are increasing our visibility right across the organisation in terms of the support, particularly in the context we're working on, and constantly working with Sarah and the team around the wellbeing offer, making sure that we maximise that. And just to, you know, we've done a lot of work around long service recognition. We've now told anybody who's worked more than 25, 40 or 50 years to make sure we've captured everyone. And there's about over 500 people who were through the old process where you have to kind of apply, that we've now identified that we were proactively got sessions in place to go and celebrate those long service awards, and also the staff recognition awards. Thanks to Louise to taking part in that, and others, and the committee we coordinated. We had over 300 applications for the staff recognition awards. That we know they're just a flavour of what goes on in the whole health board, but some amazing, you know, individuals and teams that we will be celebrating with on the 24th of March in the staff recognition event, which I couldn't have been made aware of. So so I was going to just finish on that note and just to thank all the staff and everybody who have, you know, worked tirelessly over the last 2 months to maintain services in really challenging.
Any comments or questions to?
I think probably, Nicola, just on behalf of the board, really, to say our huge thanks from the community to members of staff and volunteers and all those who work in it's been an incredibly difficult time nationally as well as locally. And I mean, it's all been professionally handled and supported. And, you know, just to say thank you, because it's just been very difficult. The weather is unpredictable, as we know, and the winter experience can be difficult. And the floods and all sorts of things are happening with the weather. And I think that it's just been an opportunity to say to you, particularly, and to all the staff around them, huge thanks.
I think everybody would endorse that. The staff have been fantastic and very convey that. Okay. We'll move on then. The report from Aneurin Bevan Community Health Council we have in front of us representative. But do we have any comments or questions? Pepper?
Yes, there's something mentioned around signage and really comms the patient experience. And we all know how frustrating and difficult it can be when you can't find out where you want to go. And I wonder if this is something that we perhaps should look at more broadly. I think there's things like signage for refuge areas, for example, that may not be at a good height any longer, where traditionally they would put at eye level rather than waist level. So where more people can see them, that sort of thing. And I wonder if there's the opportunity for us to look at our signage in the round and make it as accessible as possible, so that people don't get, you know, frustrated and lost. And I mean, there's, you know, ultimately there could be harm, couldn't there, if people can't find out where they need to go in a hurry. So I just wondered if there was something that we could do to look at that in a more kind of holistic way.
Question recommend, because I know you've been picking some.
Yeah, no, it's a really important one, and it's one we're particularly looking at around how do we make it really easy. So you'll see on some of our sites already. So in the World Web, for example, started to colour code the different levels, colour code the paint the walls different colours so you can follow certain paths. So and to try and simplify the signage as well, because we know it's incredibly confusing there. So we have got a number of pieces of work going on different sites around getting rid of signage which is just old and out of date and wrong because we reconfigure services, and then looking where we can, given the constraints of the tertiary capital that we'll come on to later, around being able to just change the colour of the walls and make it really simple to get around and make it really simple. Try and follow a lot of the guidance around dementia as well, and using that as a core principle for our wayfinding.
That's great, thank you. And I just there's some consistency across sites as well.
Yes.
So I think that's really helpful. Thank you.
Just to add to that, I think it is an important point. And one of the things that is just part of the whole patient liaison communication discussion we've been having is many of our hospitals have got a very clear front desk to be able to support there. Somebody can, you know, an information desk can help finding of the Royal Gwent, I think, is an exception to that. And again, it's about that consistent offer. So we've just been kind of doing a check around all of our enhanced local general hospitals and community hospitals to try to make sure we've got a consistent offer, and you know, whether that's through the volunteer service or through our own workforce, how can we improve the support, particularly the Royal Gwent? Because I think the other sites benefit from that kind of central desk that does help directly throughout the hospital.
Provide you find the central then.
Yes. In addition to this, is in addition to the signage, obviously.
Yes. No, thank you.
Especially when there's 4 entrances.
Yes.
So
Thank you.
Chair, if Gemma was here, I would, as usual, thank her for the reports. I did really helpful. Just a small point, in respect to Rowan and the Oak Ward, we have with it, there was a case where somebody noted that they had to order their meal 2 days in advance. I'm just wondering if that is usual and what happens when we have patients on those wards, and how, in particular, people with dietary restrictions for cultural reasons might be accommodated in that.
Get one take that. Peter.
And it's a really good point to make. And as an organisation, we've undertaken a patient dining review, and we've spoken to patients, we've spoken to ward staff, and also our facilities colleagues who deliver that service as well, and also done it in collaboration with our dietetic colleagues as well, to make sure that we are understanding the requirements in terms of healthy nutrition, but also for cultural needs. We've collected that information, and we're going to be reporting it initially to the executive team on the 2nd of February, and then we'll bring that forward to the Patient Quality Safety Outcomes Committee for further review. So just wanted to let you know that work is ongoing, and it is part of the challenge, and something that we completely intend to do is make sure we again have a consistent offer across all our sites, and make sure we do it well everywhere.
Good, thank you very much. I look forward to seeing the report and the comments from the Patient Quality and Safety Committee. Please. Paul.
I sort of hope that Gemma gets well soon, obviously.
Oh, yes.
And that secondly, it's always very useful to get these reports because they shine the light on some key areas. The one question I think that I picked up on was about the callback situation for GPs when with working people. In other words, you ring in and say the GP will ring you. I just wondered whether there's any policy or any sort of advice to be given to people. I mean, normally it's sort of the GP will call you back within 3 hours or 4 hours, but if you actually in the middle of doing something, that's difficult. I don't know whether there's anything that can be done to perhaps look at that, but I think that's something we should perhaps give some consideration to, because we've got working people that can't answer phones at particular times. How can we get around that? I don't know whether there's any thought on that, Nicola.
Yeah, you're talking more about the staff receiving the call, or whether we can have a different system from GPs.
Or how we can overcome the problem of sort of you ring in and it says, well, the GP will ring you within 4 hours, that particular, and you think, well, you know, I'm working in those times, or I'm travelling and I can't answer. So is it a text or something that can be done to say, when are you available, and or something or other, just to make it helpful for working individuals?
I think it's very much, isn't it, for that part of that piece of about access to primary care and how people have access that works for them. So I think probably we need to pick it up through that piece of work and need to explore if there are any opportunities. So I'll take that back through to the division as part of that broader access.
Because what the comment was about working people, I think it says, is they're not able to wait for a call back from a doctor or nurse with no time frame indicated. And I think it may be, you could look at, you know, what are your circumstances? Are you able to take a call within a shorter period of time, or is it any time within that 4 hour period? For example, I'm just trying to think through to see what may be helpful to individuals who are and may have some difficulties in sort of accessing that. And the only other thing I think that I will probably raise at the meeting under the CHC on Thursday would be the transitioning from the model of the CHC to the citizen's voice. Because obviously that starts on the 1st of April. And what I haven't seen, and I'm not sure it's available yet, would be an overall plan, a work programme from the new Citizens' Voice body with regards to any information at all. And I think it would be helpful for us to know what the new model is going to look like compared to the old model. That makes sense.
We have requested that information. It is on the agenda because it does come in on the 1st of April, which is not that far away. We do need to know how we're going to maintain this particular relationship.
Notice about the CHC published to their website a questionnaire, a survey asking what people's views are on their priorities for the first year. So they are engaging with the public and ourselves on.
But is there any more strategic sort of from the Citizens' Voice Wales? Because obviously it's a different structure. We've got localised structures, but I'm not sure how it's organised or.
We haven't had that information yet, for possibly.
So there's a consultation on that taking place at the moment.
There is.
Consultation response to due by the end of this month, beginning of next month. So I think we're waiting for the outcome of the consultation before they formally issue the guidance around the direction of CVB.
All right, okay, thank you, that's helpful.
You're absolutely right, because we had an update yesterday on the Welsh Government Chief Executive call, so we're on track for the 1st of April, but the next 2 months are going to be a busy period. As Chris says, once the consultation finishes, we will get more formal information and greater clarity, as you said, from that strategic in terms of how the organisation will work. So we need to make sure that, you know, that's shared with your own selves. Yeah. Trying to discuss that in advance of April. So that we
From our perspective, it's community voice or citizen voice, and the input and how that's structured and how that is organised, how it feeds into our work and listening to patients is quite crucial. So
Gemma's given an update at the meeting tomorrow.
That's brilliant. Thank you ever so much.
Yes.
Thank you so much.
And we will respond as a helpful.
Thank you.
If there's nothing further on the CHC report, we'll report back to Gemma, and we hope that she's at the meeting tomorrow. We hope she's sufficiently recovered. Okay. The patient story.
Thank you, Anne. So we have a video to share. So this will be the first of many patient stories. We are going to try and align them on an annual plan according to items on the agenda. So we'll look at how that really knits into triangulating our understanding of quality and patient experience. But this is Bob's story, and it is a story that talks about dignity and respect for people. And it was shown at the National Healthcare Support Workers Conference, because largely his concerns are around the attitude and behaviour of healthcare support. So,
Yeah.
the technical issues.
Is there any likelihood of being able to fix this?
Give it one more shot.
One more shot.
On network issue, sorry, Chair. So I think
Network issue.
if we could move on, we'll come back.
Okay. Jenny, possibly, could you give us an overview of the issues raised by Mr. Purvis?
So Mr. Purvis describes his experience whilst an inpatient in one of our wards. His experience is he reports very highly of the surgeons involved in his care and also the registered nurses. One of the things that is interesting about Bob, he said he has had an extraordinary life, which he goes on to explain in the military. And it was a lack of respect for him that I think he found most difficult to cope with. And it wasn't one particular healthcare support worker, it was a series of, which is obviously quite concerning in terms of, we know our healthcare support workers are very high caliber, you know, get lots of compliments about them, but in his experience, he felt he was treated with a lack of dignity and respect. He has a long-term condition. He was born with a condition with his bladder, so he's permanently incontinent. And again, there was a lack of respect for him and for his dignity when he was asking for things like a bottle to be able to urinate. So I think there were a number of things. He preferred not to be called Bob. He did for this story. He preferred to be called Mr. Purvis, but again, no respect for the fact that he preferred to have to be called Mr. Purvis. So I think it was a series of things that really affected his experience and his dignity as a person, particularly somebody that's very proud. You'd get a sense of pride from Bob if you heard the story. And I think it is a really good reflection, really, to the board of we still have work to do, and we will constantly have work to do to ensure that our patients receive an optimal experience.
Has the experience of Mr. Purvis influenced the training programme for the health?
So it was fed, but so his story was played at the National Healthcare Support Worker Conference as a reflection, and that was all healthcare support workers of the impact of a patient experience. It's being fed back to the ward. And obviously something, communication is something that's very embedded within training programs for registered nurses, doctors and healthcare support workers. But sometimes when people are busy or when perhaps things, you know, are not as they should be for them, they will perhaps behave in a way that they wouldn't normally, or perhaps forget that an elderly person is still somebody who has an identity. He talks about his identity. They have an identity. They are still a person. They may be elderly. They may be frail. And he talks about vulnerability as well, which for a man like Bob, it had a huge impact because he suddenly felt very vulnerable in his bed. So I think it's all of those impacts that really influence, I think, care. And some of this is about leadership. So, you know, it's not just about the healthcare support worker. You know, you have to ask where are the registered nurses? You know, did they pick up that he was feeling this way? So I think it's a really good reflection back to us.
Thank you. Well, we have to apologise to Mr. Purvis that we've been unable to share his story on this occasion, but we shall try again because it is really worth watching.
Sure, I think it's worth trying it again now.
Oh, okay.
Try
That'd be
something. I
helpful.
can't guarantee it, but I think it is worth a try.
Okay, go on. At that point, it doesn't like him.
Is there some of us coming off the teams?
It's not about that, I don't think.
No.
It's this laptop, it is.
Okay, so with great regret, we can't see this evidence for today, but we shall ensure that it is viewed by all different moments when we can get the technology to work. And to thank Mr. Purvis very much indeed for his story and the learning that it will allow us to implement right throughout the services, not just for the health experts.
I can ask that when the live stream goes up on YouTube, viewers that would watch.
Yes.
Yeah, absolutely. Maybe I will address technical issues.
Thank you. If we could move on then to item 3, charitable fund annual accounts and annual report.
The papers included for the board today are the accounts and the annual report for the charitable funds of the health for 21-22. We presented the charitable funds committee on the 9th of January, and the Auditor Wales also issued a report and opinion as well, which we're expecting to be an unqualified audit opinion. It's presented today to the board as corporate trustees for the charity for approval. Approval then will be filed with the Charity Commission by 31st January, which is our legal requirement and deadline. In terms of key points, in terms of the accounts, we've had income donations in the year of £660,000. We've had investment income of £187,000, and we spent £930,000, which is a reduction on previous years, where last year we actually paid out quite a bit for COVID-related purchases. Net impact of that in terms of movements is that we've had a £51,000 increase in funds before investment gains considered, which is an improvement over previous years. In terms of investment and assets and improvements and gains on that, we've got a stock market gain of £480,000 and a property revaluation gain of £97,000. So that's £577,000 overall improvement. In terms of all of our assets and funds, we've got a gain figure of £628,000 and a net fund value at the end of the year, 5.4 million. It's an increase as a result of those movements. There's expected to be, as I say, an unqualified audit opinion. In terms of the accounts adjustments, there are a couple of minor things that we agreed to change, and the auditors are very content with where we've got to. In terms of the annual report, it includes an overview of activities of the charitable fund during the year, including fundraising and supported requests from services. So fundraising includes some staff activities around the Zipwire Challenge and turning ABHB pink for breast cancer support. And in terms of how we've applied some of those, we've purchased hydration bottles for staff as a COVID thank you. And we've invested in things like the PRENS project with the patient-centred care team. I don't know if Tiege is the field like that.
Thank you, Rob. Yes, I'd just like to again thank the team for working so hard on the account and leading us to a position where the indication is in. If I can just talk briefly around the annual report, if that is okay. Rob has quoted some figures, but I'd really like to peel that back just a little. Of our funds that we have incoming, 41% of those were from donations and fundraising activity. And when, again, you peel that back, some of that money will have come in very small amounts. We're very, very committed to the health services here, and it's all they can afford to donate. I would like to personally say thank you to them for that. We also have 17% of our income from legacies, and again, that is a very personal decision, and we very much recognise and are grateful for that. In respect of how the money is used, 24% of the funds that we have distributed this year, is for staff welfare. And going back to Nick's comments earlier about staff and their well-being is something that we very much value. I know that donors would be very keen to make sure that happens. 21% towards patient welfare and 37% towards equipment. And finally, I would encourage anybody who has been part of fundraising for us to look at the annual report, which will be online, and it really does give a very readable overview of what the charity has been doing in this year, and it gives a really good representation of the range of support that has been given from, for example, equipment for reminiscence therapy, all the way through to cards and stamps, so that patients that are in the wards are able to keep connected with their family in a way that suits them best. So again, I'd just like to thank the team and everybody who's been involved in donating and using.
Thank you very much, Tiege, and we would very much endorse your thanks and congratulations to people who have really worked very hard for us and given legacies and donations to us to support patient care in Aneurin Bevan, because they just make such a huge difference to the patient experience. And we're really, really grateful. Are there any questions? Paul?
I think probably just to endorse that the charitable funds actually is a sort of an additional added value. I think it makes a huge difference to when you looked at some of the headings of patient education and welfare, building refurbishment, research, staff education, welfare support staff and equipment. And I mean, it's all adding things on that actually isn't necessarily available on the NHS budget as such. So I think that just to be as supportive as we can of the charitable sort of situation, and to remind people that, you know, if there are funds available and they wish to donate, it makes a big difference in the longer term. Thank people for their contributions.
Thank you, Paul. Any further comments or questions? No? Thank you very much, Tish, for all your hard work, and Rob in determining the account. If we move to 3.2, the capital programme, Chris?
Yeah, so I'll try and keep this paper quite simple. I appreciate it's quite complex. So this will be my quick bit and chip summary version of the paper. So essentially the way we get capital as an organisation, we get two main pots. So it's the All Wales capital schemes. So those are the big projects that we bring to you for approval as individual schemes and come with the business case model, either a full business case approach or a business justification case. Then we have the primary pot, which is our discretionary capital allocation, which is the majority of the focus of the paper today in seeking to approve our opening programmes for next year. There are then some other pots that we can fish in for capital. So there is a particular specific estates facilities advisory board fund, and that's EFAB is the acronym in the paper, but that essentially gives us funding around for essential firework, work around decarbonisation, and then essential infrastructure elements. The challenge and the difficulty and looking forward to next year is that used to be a 100% funded scheme. It's now a 70% funded scheme, with the Health Board asked to contribute 30% towards those schemes. And you'll see we provide an allocation on what we think we can afford within the scheme against those. And then the other source of capital we have available to us next year is the integrated capital fund. So that's funding through, which is through the partnership forum and approved through the regional partnership board structures. Traditionally, there's been two other pots of funding available to us for capital from Welsh Government, and that was a specific informatics programme. That programme does not exist next financial year. That's a change in practice by Welsh Government, and some funding is moving via DCHW rather than to individual health boards to support wider transformation programmes. And there was previously a specific fund for imaging, so those big imaging intensive machines that we use. That pot doesn't exist. So that's another pressure that we have to take as an organisation within our discretionary capital programme. The other thing that's worth noting then is we have had a reduction in our capital allocation over the years, focusing specifically on discretionary capital. So we used to receive just over £10 million as our allocation. There was a cut at an All Wales level by 24% last year. We've had some of that cut put back to us in what's proposed in the budget for next year. So we get an allocation of 9.5 million. And as I said, we then have to make an allocation towards the cost of the EFAB schemes at 30%, allocated around £600,000 for next year. And then the other element you'll see is that with the All Wales schemes, essentially we get a locked off position at the end of November, and any under or overspend as an organisation, we then have to broker between years as an impact on our discretionary capital programme. So the way that this has come together and what we're asking for you today to do is to approve the opening programme for next year. We're actually doing this a lot earlier than we normally do this. We normally bring this to you around March time. The reason we're trying to do this earlier and ask for your approval now in January around the schemes that are in here is about supporting that brokerage position to enable us, because we have an underspend in some of our All Wales Capitals programme, approval now will ask to pull some schemes forward into this year for those schemes that have a higher value and recognise that they therefore need board approval. We're also got a reserve list of schemes here that we're seeking board approval on, and that's hopefully to try to stop having to come back to Chair's action for schemes and allow us a bit of headroom. We know that things do slip in capital land and position changes with Welsh Government, and we often get opportunities at the last minute with changes elsewhere on wider capital schemes across Wales. So it's important we've got that sort of reserve list ready to go of schemes that we want to do and put out. There's a few specific things I wanted to mention then. So we do have a really robust process which has gone into this, pulling these together and putting together these proposals. So it's heavily about driven by our divisions and by our operational and clinical teams. So all of the proposals will hoover up from the divisions, and then we'll have that process of going through with them the rigour and challenge and the process there. And then the agreed programme here is set through our capital group, which involves all of our divisions, senior clinical leaders from the divisions coming to agree that the position of what we can do. There is not enough money for all of the schemes that we would like to do, and we've had to draw the line somewhere. Where possible, we try and draw that line to focus on our greatest area of risk. But as you can see within the list of schemes, there are still areas with high risk scores where we've not been able to afford them within the capital programme. Probably that's around the size of some of the schemes and the focus of some of the schemes. So we are making sure we've got an assurance process for all these where we look at have they got an appropriate business continuity plan, if they've highlighted that as a significant risk, and are we getting assurance from the division that there is plans in place if we're talking about equipment or other areas that they've highlighted as a risk, because we know we haven't got sufficient capital to cover off all our risk areas. Which is one or two other things I wanted to mention. So with the discretionary programme, that programme is for ours to allocate. The majority of that we are allocating against things that are around risk, health and safety, things that are clinical concerns. But we also do try and focus that as well around our strategic opportunities as well. So you see then there some of the allocations around Cordell is actually giving us outpatient facilities that support our outpatient transformation programme. So trying to balance off all of those risks, all of those service areas, as well as then getting a bit of strategic intent. And the other thing I wanted to particularly highlight in there, you see in there a large allocation for WinPath, which is our blood transfusion system as an essential change that we need to do. Our blood transfusion system becomes end of life on the 31st of March. And you'll know that as a board, yes, we asked you to take a decision back in July around moving to an upgrade of our existing system, only because there has been a national process to develop a national laboratory information management system. Hasn't been able to provide a viable alternative solution for us, which as a result means we are allocating 70% of our capital allocation next year to the IT infrastructure costs of that. So we are going into negotiation discussion with DCHW and Welsh Government about that. I think it's important to recognise that we hope we'll be able to draw that back to give us some more headroom on the other item. So hopefully that was a very quick overview and gives you a sense of what's in here and what we're asking you to approve and support today. And then the final thing I'll say now is it's a really challenging process in getting all this together, scrutinising things together. So a massive thanks to, in particular, two people in particular, so Kelly Jones from the finance team, who does an absolutely incredible job in making sure that we got a really good reputation for getting capital from Welsh Government and spending it effectively and making sure we get every pound out in every area, and Kelly does a superb job, ably supported by Mike Gallery, our discretionary capital manager, who again makes sure that we've got that robustness of the process around.
Thank you very much, Chris. It was really helpful. Are there any questions? Pippa?
Yes, just first of all, I want to say thank you for the report, because I think it's really good to have such a sort of comprehensive breakdown and gives a really good understanding of just where the money is being spent. And obviously there's an element of this which is equipment and maintenance that are things that have to be done. And then, you know, as you've explained, there is the other area where we've got a little bit more choice, I guess. And I just, you mentioned it very briefly, but I thought what would have been helpful to me was if we could layer that with the estate strategy so that we can see a direct link between the two things. And it was the sort of area where I was thinking, well, I'm not quite sure how those two things link together. And I guess it's just a comment really on the next time we see this report. I personally would find that really helpful.
Thank you. I think we'd all endorse that. Jenny?
Yeah, I just had one comment up. It was about the backlog maintenance. Obviously, understanding what you said around you have to balance. But obviously, it is disappointing that we don't have that 820,000. So I think we probably agree to go towards that backlog maintenance. And the question is linked to actually another item on the agenda in terms of risk. So notice on the risk for this area, it actually has met its targets. It does say it will be managed, but I find it quite difficult to see how it's met its target score. And we know that there is a growing backlog. So not necessarily discuss that element now, but I do think that perhaps needs to be. But bearing in mind the risk was remodeled, I think, in December last year. So it is, you know, I know we are where we are, but just what I meant.
Yes, we did have a report some 18 months ago, which really underlined the risk to backlog maintenance. So we must bear that in mind, and I think that should be associated with a review of the estate strategy. And you know, it's a bit concerning that we are not disposing of any properties, given agile working starting to be affected. So perhaps we can take that up when we review the data strategy. Goes back on maintenance was an issue. Dan.
I'll just take a couple of bits. You've already touched on the Master Lab wind path placement. I'm very keen if we can get some regular updates on those conversations with Welsh Government and also the progress in implementing that right before the 31st of March expiry date of our existing system. More generally, we've highlighted in this report that we're effectively doing the bare minimum we possibly can on informatics and digital and technology because we don't have that capital funding available. This is very much keeping the lights on and not necessarily doing anything transformational, which might help us in some of our other areas. And I think it's a bit of a shame that we're not able to do those transformational pieces that will actually help us deliver more efficiently. And that's a big shame. Similarly to what Shelley has identified for a conversation later on, we talk about risk. Again, we have a risk around infrastructure and cybersecurity failure, where we are managing it, but this capital appears to be doing the bare minimum to keep the lights on. And I'm not sure whether we need to reprofile that risk or not, based on that.
Yes, absolutely. Nicola?
Yeah, it's just to reflect on some of those comments. You know, I am worried about, you know, the demand on our capital programme versus the resources that are available. I think the team have done a great job trying to balance all of the risks, but we've got informatics of risks 20 of 7.5 million, and we've only got 2.8, and then we still take 20-30% of the programme. The backlog maintenance issue we've not managed. In the reserve list, you'll see the pharmacy replacement. That was a much bigger scheme. It was to do some of the infrastructure as well as replace the robot. That is literally just replacing the equipment now, because that serves drugs to lots of the GPs all around Newport. So if that, you know, when that breaks down, so you know that's a key issue. The nurse call system at the Gwent, which I know high on Jenny's agenda. The lifts. You know, I think the point around trying to dispose of our estate. So St Willow's is a top priority for us in terms of trying to get out the old estate. But we need capital to enable some of those moves at the Royal Gwent, and some of the Royal Gwent infrastructure we know now is challenging. So it does, this agenda does worry me in terms of and as a board, I think we do need to, you know, I think we are trying to maximise our resource as best as possible to minimise risk. There is a lot of risk in this, and we do really need to be as creative as possible. And I think we are pretty good in terms of recognising this as a national challenge. We are trying to do everything we can to maximise opportunities when funding does become available, like the EFAB schemes, having those that ability to have the reserve list ready so that we can act quickly on last minute funding. But I do think this is a key risk that you know, we pick up through our risk register and consider, you know, our appetite for this. But some of them we are absolutely restricted in terms of the resources available. I just wanted to kind of thought about it. No, it's an uncomfortable thing for me because there's lots of things we can't do that we want to do. Yeah, we need to do. Absolutely agree. I think we don't endorse that, and we must keep it very, very careful. Yes. Are there any further questions? No. Thank you very much. We go on to 3.3. The review of the current arrangements for midwifery-led services, please, Jenny. And welcome, Linda and Claire.
So, Jane, I'll just briefly introduce. So, if you remember, we made a decision to extend the closure of 2 midwifery-led units until the end of January, due to the staffing difficulties that had started, or the suspension. Sorry, I should use the word. The suspension of those units due to the issues that the board received last July in terms of the safe staffing and some of the complexities of the service delivery. We commissioned an external midwifery review. That's been completed, and what you have today is the preferred option for the service moving forward in the shorter term. There are some opportunities to review the service in the long term, but clearly that needs to be worked through in terms of both public discussion and staff discussion as well. Linda, are you going to just briefly?
Yeah, I'll just be very brief. I think you've covered the main points, Jenny. As board is aware, the temporary changes were introduced in May 22 due to significant workforce challenges, but also the data did demonstrate that there was significant underutilisation of our midwifery-led units. And we changed the service to ensure staff could be redeployed to support the safe delivery of services across the health board. Despite significant work in regards to recruitment of midwives and also the work undertaken to introduce new roles to support a prudent approach to recruitment, there does remain significant workforce challenges. Currently, we've got 10 whole-time equivalent vacancies for midwives, which is a significant reduction, but we're also very aware there's a national shortage of midwives currently. So since May 22, since we introduced a temporary service, there's been no reported incidents in relation to mother and baby safety. We haven't received any complaints in regards to change in service, and to date, staff feedback has been really positive and reporting an improved work-life balance. So the purpose of today is to ask board to review the temporary change introduced in May 22 and whether this should proceed to potentially public engagement on potentially making this temporary change a permanent change with further staff consultation. And I've also got Claire and Jane with me that could ask any questions. Thank you.
Thank you, Linda. Claire, Jane, would you like to add anything?
I think we're really pleased in the way that the Grange has been used, and I think the important thing to point out is that patients, women who are birthing under midwifery-led care have voted with their feet to go to the alongside midwifery unit in the Grange. I don't think that's a fad in terms of being in a new hospital. I think that brings in an element of safety that many women want to have. And therefore, I think we're almost following not just with the workforce pressures, but we're actually much more cognizant now of how our patients want to use our services across the health board and have that reassurance and safety around the alongside midwifery unit based in the Grange, while having the opportunity to have normal births under midwifery-led care. So I think there are some statistics there of usage within the paper.
Yes, thank you. They're very helpful.
I mean, I would just add that, you know, we have a very large proportion of women who do utilise midwifery-led births. You know, we had over around 1,000 women in the current year. So it is well utilised, but the periphery midwifery-led birthing areas are not as utilised.
I think the statistics are very helpful to any decision that we make. Thank you. Are there any questions? Paul?
Could I ask I think part of the point is about talks about moving the pool to facilitate could also be considered. So is there a cost associated with that, or is that going to happen, or what's the sort of thoughts on that? Because it's got could rather than should.
We would need to cost that up and see whether it is a potential for moving into the Grange based on the environment. But it's certainly something that we would like to look into to make sure that women have more of an option for pool birth.
Yeah, I mean, I support what's being proposed. I think that am I right in thinking this is a sort of a short-term view with regards to a more detailed discussion at a later date? What's the
we obviously have an in-committee discussion as well, but so this would be making the current temporary changes, so engaging with the public, consulting with staff on making the temporary changes a permanent arrangement,
right,
based on the evidence that we've obviously accrued over the last few months, but also the quality of service the women are receiving at the Grange and the choice they are making in many cases to receive that service.
Yeah, well, I support that.
Ewan and then Shelley.
Yeah, I mean, it sounds quite positive what's been I'm just wondering, we got a measure of what the cost difference has been between what was there as I put it as an old service versus what the changes have been over the last 10 months or so?
There's no cost impact, unless Claire corrects me, because we've utilised the midwives in a different way. So whilst we've suspended those services, the midwives have been used to enhance community services. So we haven't seen a net reduction in staff.
That's correct.
But in the report, it said there was a reduction in cost.
That's correct, Jane, isn't it?
Yeah, there's what we have seen is a reduction in variable pay because we weren't able to support the full staffing of those areas. So that's where there's been a cost reduction.
Yeah.
Do we know what that was? We measured that over the last 10 months or so.
How much was it, Jane?
How much was it, Jane?
It varied from £2,000 up to £12,000 per month.
And that wasn't budgeted, but was an overspend.
It was an overspend.
An overspend.
The actual bank now for the areas such as YYF is very, very minimal.
Linda?
Just to say, we do have those costs. We did put it in previous papers, and if that would be helpful, and we can certainly get those costs. But it has been around reduction in variable pay, particularly at YYF. And that's when, as Jane said, that's where we've seen the reduction in costs, but we do have that.
I think it'd be helpful if you could circulate those, Linda, for clarity.
In most of our papers, just to have these costs, especially as we are proposing, looking at what the service provision is going forward, just to see what the changes are.
So it should bring us back to the baseline pay rather than having the impact of the obviously the increased bank and incentivisation.
Jenny and then Louise.
Just 2 points in relation to the absolutely support all of that. I think the point that always about giving those members the option, as many options as possible. I think that would be something we really ought to try and facilitate. And I mean, presumably, I don't know anything about this, but I assume that we could use the existing equipment and relocate it. That would be, and the other question, really linking back to what we were discussing earlier about the estate. Presumably, if we move to this model, will there be a reduction in those other hospitals where we haven't got such a big footprint? So will that be space that we can utilise for other services, etc., without having to enter into new leases, etc.?
Yes,
I don't know. It's going to be a question for me in particular.
In terms of space and equipment?
Yes, as regards to the space and the actual environment, what we do use those spaces for antenatal care, for antenatal education, for postnatal care, for baby checks, etc. So there is an opportunity for us to use those, offer yoga. I mean, we hadn't been able to do it through some of the COVID, but it's certainly something that we could increase. But some of the equipment around that, we could certainly use it.
Actually increases local availability of things like the antenatal, postnatal care, other activities, rather than reducing the space completely.
I think, it's about the utilisation though. So, for example, for me, if a particular area is not being used and it doesn't have equipment in it, then that should be made available when you don't have clinics, so that somebody else can use it. Yeah, we have that. Yeah, that's the sort of things that we need to be looking at. And I'm not saying it doesn't happen now, Jenny, but because I have been to some of these places and rooms are not being used, and
I think it's a general point, isn't it? I think one of the things that we will be doing over the coming, what the review has enabled us to do is take a broader look, I think, at the configuration of maternity services, but also some of the what we're providing and where. And there is a broader piece of work. I think this is an interim step to stabilise the service, to make sure women have a choice, but make sure we're safe. I think there is a broader piece of work over the next 3 to 5 years with Jane and Claire around, with our mothers and babies. What is it that we want to need to provide? So I think that is probably picked up in the broader piece of work, Shelley.
Thank you, Louise.
Yeah. Well, I approve with the suggestions that we've made for moving this forward, but I'm just wondering what the morale is like with the staff. Has that improved since we've looked at working differently? with some of the pressures that have been highlighted in the past couple of months?
Yeah, I think Louise, I know Nicola's met with the midwives. I've met with the midwives since I've been here. I've got another meeting coming up in a couple of weeks. I think there's definitely been some improvement. As ever, there are always concerns and issues, but Jane works those through. And actually, the impact of this hasn't, we've actually been able to mitigate some of the impact, haven't we, Jane?
And certainly from the community staff point of view, they were very much in favour of this way of working. They felt it was an improvement for them.
Okay.
Anna? Okay, thank you very much. I just wondered, as part of the review you've just had, do you have any formal conversations with patients at this stage, or in coming to these conclusions, and how do you propose to engage with the public, bearing in mind there are limitations as to what the service can actually offer?
We've engaged with the CHC throughout the process. There's been a high level of staff engagement, and certainly Jane has a very active group of mums who work with her from a public perspective. Clearly will be led by Chris's team on the formal engagement process, and obviously Jane is linking with Sarah and the staff consultation, because there are some issues for staff. But Jane, is there anything you wanted to add?
No, I don't think so. Thank you, Jenny.
Any further questions, comments? Paul?
It's just the two issues which are about the expansion. It's the word could be expanded, and also the could be considered. And where is that? Because that is a possibility rather than they should. In other words, we're going to consultation. So will part of the consultation be, well, we're going to expand it so that there will be antenatal and postnatal care in these settings? What do you think? We are considering moving the pool to the GUH. What do you think? Is that going to be incorporated within the consultation, or could I request that it is incorporated, but there will be costs associated with it? So just the word could. The word could that was within those sort of those two parts, really.
Jane, comment.
I mean, there would be a cost associated with moving the pool, as I've mentioned before, but around the wording, then of course that can be we can review.
I mean, I think, Paul, the could is probably a question for the public. And as I say, the moving of the birth pool would need to be built into a future capital programme. It's something that we can test in looking at choice. And I think obviously, our premise has been to utilise, certainly locally, the antenatal, postnatal and other sort of pastoral opportunities for support for women. So that'll be part of the discussion.
So would the birth pool stay where it is and be utilised where it is currently, with a view to possibly moving it?
Yeah, it would be possible.
That's what we're looking at. Just to clarify that, that's all. But obviously options.
It's a possibility.
In the future.
Subject to capital.
Right.
That we could make that.
Okay, any further questions and comments?
Well done.
Are we happy then to support this proposal and the proposal to engage with the public on making this temporary change permanent with further staff consultation?
Yeah.
Agree? Okay, thank you. Could we move to item 4.1, the council service? Thank you. Very good. The council services annual report. James.
Thank you. I'd like to present my first cancer annual report to the board. The report sets out our progress against the Health Board's cancer strategy 2020 to 2025. And the strategy itself sets out our ambition for how we are going to focus our cancer services on prevention and early detection and the delivery of timely patient-centred pathways. The report is presented in the context of an exponential increase in demand for cancer services compared with the pre-COVID era. There are a number of our cancer services that have seen referrals 30% higher than at any point pre-COVID, and this wasn't anticipated, and it's something that we've had to adapt to very rapidly. probably the best summary of the situation we find ourselves in is on page 3 of the report, where there are 3 graphs that show SCP, which is single cancer pathway, compliance, treatments and referrals. And the 2 graphs on the right-hand side tell the story. The cancer services continued throughout the COVID pandemic, but the delivery of services were in their trough in May 2020, in the earliest part of the pandemic, but the services recovered rapidly and demand has increased since. And in fact, the number of referrals and the number of treatments being delivered is higher now than pre-COVID. That increase in demand really explains the graph on the left-hand side. Just to remind you, the Welsh target is that 70% of patients should go from initial referral to definitive treatment of their cancer in 62 days. That's what the SCP pathway is. And you can see that as demand increased and we brought new services online, our performance against the pathway deteriorated. However, it's been improving since June, and the improvement on this graph that goes to October has continued. We're expecting a plateauing in January, but we're hoping to have recovered the cancer pathway to the 70% compliance by April or May this year. The focus that's outlined in the annual report really describes the activities of the various cancer teams. A large part of our focus in the last 12 months has been around delivery of timely cancer care. My belief is that you cannot have high quality cancer care unless it's timely. So that's what we focused on. And we asked all directorates managing cancer patients to focus on ensuring that the first contact with their service occurred within 14 days of initial referral. And at the same time, we brought online a new diagnostic and pathology resource to ensure that we could cope with that surge. And the pathology outsourcing that has been discussed previously has been particularly successful in helping us to recover a lot of the pathways. And it's that focus on 14 days, diagnostics and histopathology resource that has really led to that improvement in SCP compliance set out here. The teams I work with have been truly amazing in innovating to redesign their pathways. And we've also, despite the pressures we've been under in the last year, brought online some other approaches to cancer care that are now being replicated elsewhere in Wales. So one of these is the Cancer Navigator programme. So we recognise that up to a third of patients whose care extends beyond 62 days, their care pathway's been extended because they've cancelled or rescheduled appointments. And our analysis was that this was because patients weren't receiving adequate information to allow them to judge the benefit to them of a rapid cancer pathway. So the Cancer Navigator works with clinical teams and with patients to ensure that everybody communicates as effectively as possible on what can be a very complicated journey for patients. We also have benefited from innovation initially started in Swansea Bay, in that we have a rapid diagnostics clinic for patients with non-specific symptoms who would previously have got lost in the system, really. And that clinic is busy, incredibly successful, and about 15% of people referred to that clinic receive a cancer diagnosis in a very timely, multidisciplinary way, in a way that they just wouldn't have in the past. The year ahead, we're beginning to slightly shift our focus from the delivery of timely cancer care, because I think we're on the right track there, to the other very important bit, which is patient-centred cancer care. So we're going to be looking at our rehabilitation pathways, how we support patients emotionally on their cancer journey, and how we begin to address the issue of cancer survivorship, as with a lot of the new cancer treatments available in Wales, cancers that previously have been very life-limiting become chronic conditions, so that the diseases and being cured by the drugs, but it's being held in a way that it just wasn't in the past. So we're going to have to adapt as a health service to help people manage for longer and better, so that they have a good quality of life. And we will, of course, continue to work on our biggest challenges, which are the consistent rising demand and the chronic workforce shortages that affect both us, the rest of Wales and the rest of the UK. So I commend the report to the board.
Thank you, James. It was really helpful, and it's very heartening indeed to see the improvement that has been made in family care, because that is really so important to everybody, and the outcome for patients, and it gives them assurance, and that's really good. So congratulations to the staff for making such an important improvement within this year. Are there any questions, Paul?
Yes, can I enjoy? I thought incredibly helpful report there. And I did want to put on record huge thanks for the capital projects, particularly the breast cancer unit and the satellite radiotherapy unit, both of which I understand have now got full approval by Welsh Government, which I think will make a huge difference to those particular areas. So really well done to all involved in those particular projects. I just wondered if I can ask about the issue of smoking and vaping, and whether there's any, what is the, with regard to our sort of programme, any research on the sort of difference between sort of tobacco via the normal cigarette compared to vaping, and whether or not that's been factored into, because that seems to be becoming more and more.
So I think I could maybe say something about vaping whilst Larry collects her thoughts. About smoking cessations. Obviously, I'm a chest physician by background, and I've been actually very worried about vaping ever since it began to become popularised. Now, there is good evidence that if your aim is to stop smoking, that vaping can provide a helpful bridge from being a smoker, a sick nicotine addict, to being a non-smoker. But really, in my own discussion with patients, I also highlight to them that once they have come off the cigarettes, they also need to come off the vapes. So the vape industry is very largely unregulated. I don't necessarily have a high degree of assurance, as many of the vaping companies are being bought by the tobacco companies now. There is very well documented in the medical literature both deaths and permanent lung damage occurring as a result of vaping, particularly with some of the flavoured vape liquids. And again, the message to my patients is, if you wouldn't normally smoke the thing, don't smoke the vape. So chocolate cake flavour, strawberry flavour, raspberry flavour, just don't do it. The safer vapes appear to be the nicotine ones. So I'm very worried that unless we address it now, it will be our public health challenge for the future. So vaping has to be there on the list, but we do need to help people to stop smoking, as that's far more harmful.
And what I've noticed in some of the, particularly the high streets, is the new vaping shops that are developing. I just wondered, obviously tobacco is licensed. And is there a licensing programme for local authorities with regard to the vaping shops? Because I think that it may be a conversation at a, something that you might have to take up at ministerial level to say, right, we are trying, part of our programme is on smoking, which is tobacco, which is cigarettes. However, we've now got a new model in town, which is the vaping, and we need to make some sort of programme or some sort of activity or advice or whatever it is on that, because I think the younger generation in particular thinking, I'm not going to go to cigarettes, but actually vaping is the in thing to be. And I've seen travelling home, for example, young people getting off the school bus, and I've seen the trails of them. I assume it's sort of vaping, sort of. And I'm thinking,
would you want to comment a bit?
Worrying about that.
Yeah, thank you, James. And you've summarised, I think, the evidence around the impact of vaping very succinctly, and I won't go over that, but the point that you make with respect to the risks for the future generations and children and young people is one that schools within Gwent and the Healthy Schools coordinators, and frankly most of the organisations that work with young people on Patch, have highlighted to us. We have developed some guidance for those young people's organisations, so not just schools, but also informal youth settings and the third sector,
to help them understand the impacts of vaping on young people, but to also build into their programmes of health education and substance misuse education the aspect of vaping. Helpfully, Cardiff University runs something called the Schools Health Research Network, and they run a survey with young people in secondary schools across Wales, which looks at lifestyles and behaviours. And under that smoking section, it also asks questions about attitudes and behaviours towards vaping. And we can see through that survey that that is increasingly becoming as much of a problem as smoking tobacco. So just to summarise, we have put together some guidance that's not been disseminated yet, but we will, and our approach very much is to integrate that into that wider work around healthy schools and healthy settings for young people, so that it's relevant to the realities that young people are experiencing at the moment, and those that the professionals that work with young people are reporting back to us.
That's hugely encouraging, because I think that there was a gap in that thing with regard to advice, support, and what's available within schools, particularly, which is all about quit smoking. I think, well, okay, yeah, but it's vaping, and knowing actually there are some huge risks associated with it, and to emphasise that and to make sure that there are there messages on vaping which says this is health? Sorry to labour this one.
Errol, sorry?
Are there labels on cigarettes going, you will die if you smoke? There's anything on vaping?
We don't have the equivalent messaging on vaping products.
But it may be that, again, I think we need to have this big conversation on vaping.
So I think so first of all, I agree. I feel very lucky living in Wales, as Wales has shown itself, like Scotland, to be prepared to sort of go out there and take sort of difficult public health decisions. There is a constant balance between the libertarian view that anyone should be able to do what they want, and the communitarian view that actually we're all in it together and we should try and help people. I would reflect that tobacco has been around since the time of Sir Francis Drake. We've known for nearly 100 years that it shortens your life significantly, but yet the regulation has mainly been through taxation. Children are the people I'm most worried about. Yes. I will tell you that public health interventions in children are actually a very specific, difficult and niche area. If you tell adolescents in particular that something is forbidden and dangerous, they usually go straight out and do it. So the message is a very difficult one, and actually it may, on the face of it, seem like a good idea to write on a health warning on the side, but that may not actually achieve the aim that you want. And the other area that we haven't highlighted, and it is still illegal, but the way the police deal with it is different, is around cannabis. And that's another area where there needs to be myth busting. We do not know whether vaping is safe. We just believe it to be safer in the short term than tobacco. And similarly, people believe that cannabis is safer than tobacco. Whereas as a chest physician, I know that people who smoke cannabis regularly are likely to develop emphysema 20 or 30 years earlier than tobacco smokers. And it's not known if that's the way people smoke it or what's in the chemical itself. And we also know that regular cannabis smoking has a very negative impact on people's mental health. But yet the word on the street, in inverted commas, is that cannabis is safer than tobacco.
Pippa? Yes, and again, not wishing to labour the point, but I think it's a really important thing to raise, Paul. And I wonder if there is anything that we can do in terms of communication. Just because there is I think the word on the street, as James said, is that actually this is not a harmful thing to do, that it's quite okay to do it, it's perfectly safe, there's no risk at all associated with it. All it produces, as somebody once said to me, but it just produces steam, as if somehow the smoking tobacco is the secondary smoke is the problem rather than the risk to the person. So I just wonder if there's some gentle messaging that we can do within our communication. So we've got lots of signs and things that say there is no smoking or vaping, and perhaps we need to just, when we're starting some of our stop smoking messages, perhaps we ought to put something about vaping in the same message, just so that we have this kind of underlying message that goes out that says this is another harmful substance. So it's just
Yeah,
a
we
thought,
can-
but thank you.
We certainly can do that. I think that would be very helpful suggestion. Thank you. Helen?
Thank you. Just obviously say well done, I think, to all the team for this report. It's encouraging to see how small incremental changes are now beginning to have an impact. And also the obviously holistic and multidisciplinary approach. I think it's obviously we're always held by that sort of SCP or single cancer pathway target, but the things that have the effect on the patients are all the other things that you're doing, and all the other, the patient experience survey shows some very good results despite COVID going on at the time. But also all the other ideas. I think the navigator sounds a great idea. People getting lost in the system, not knowing what's going on. So some great innovations there. I think so many people are obviously contributed to this and are really fired up about improving everything in a holistic way for the whole patients along the pathway. So well done to everybody. Keep up that work. It's great to see some progress at last. I'm sure for the team, it's good to see that.
When we held the workshops to try and hear from the teams what the barriers were that they were experiencing, we had to hold 2 workshops because we couldn't fit everybody physically in the room at the same time. So that probably tells you more than anything else just how many people there are. And it's a shame that Leanne's not here because she's been amazing on the operational side of working with the teams to get us where we are. So it really has been a good bit of teamwork.
Thank you very much, James, and congratulations to the staff for the huge improvements in patient care that have been effective. And we look to see what the next report gives us. We will take up the suggestion about the gentle messaging. And as I'm held to account by the Minister for smoking, I will certainly raise that with her to see what can be done in the short term.
Thank you.
Could I just ask?
Oh, sorry.
I'm sorry. Before you, quickly. So, thank you for the report and like everyone's, well done and so on. It just occurs to me that there are a couple of touch points in the pathway or in the flow with the third sector, and I'm just wondering how so those in particular might be prevention, and then I'm just wondering if we're taking a strategic approach to that and how what mechanism that might.
So at the front end of the pathway around prevention, we've already met with the Moondance charity, which is a Welsh charity set up by the owner of Admiral Insurance. And they have a commitment to actually one of our highest or areas of greatest concern, which is lower GI cancers. So they have a commitment to working in that space to improve results for patients in Wales. And in fact, just yesterday, I was communicating with their new chief executive saying I would like to meet up to see how they can work with ourselves and public health around that really important bit, which a lot of patients with lower GI cancers present too late for us to be able to produce the best outcome. And it's a really good example of the kind of inverse care law that the people who most need to respond to screening are the people in risk groups. And I think it's a really exciting space to work in. Another person who has been absolutely amazing is Tanya, who's a member of Jenny's team, who's been leading with the people in the council team on that person-centred care bit. And I think cancer survivorship and supporting patients through the cancer pathway is a really good area for us to work with the third sector. So we've been looking at Maggie's Place up at Neville Hall to provide a space for patients going through the cancer pathway. And this will be something that we'll be picking up next year. I've been pretty hard-nosed about the approach for this year because unless you get a timely diagnosis and treatment, you're unlikely to survive, get the other benefits that we're talking about. Now I'm more confident that we are in a much better place there. Now we really want to start working on the experience as well. I realise that's quite a medical approach to these things, but I am listening to my more holistic colleagues now. So,
Thank you. And thanks very much for that. James, can we move to job planning?
yeah. So the process of job planning, for those who don't know, is meant to be an annual process by where a doctor sits down with their line managers to discuss what they do on a day-to-day and a week-to-week basis to deliver care and meet the needs of patients. All of our doctors have job plans, but many of them have not been reviewed in the previous year. There was a review by internal audit of the job planning process within the health board back in 2018, I think it was, and that provided only limited assurance. A lot of quite good work was done at the time pre-COVID to try and improve the situation in the health board. And then job planning was suspended during COVID because nobody was working in a stable way from week to week. So there really was no purpose in job planning people because what they were doing was very reactive. Obviously, we're in a very different situation now, though we are not back to everybody working as normal as we've embedded the Grange. But what we certainly need to do is to get down to those detailed discussions with people about what they do on a weekly basis to make sure that we get good value from the most expensive element of our workforce, the medical staff. Now, my analysis when I started as medical director was that even if we improved the system that was in place so that it was working as well as possible, it would still not achieve what the ultimate aim of job planning is, which is that clinicians work as teams to agree what they're going to do collectively. I think that's really important because it allows for transparency and it allows for scrutiny of the way in which individual clinicians work in the most effective way, which is scrutiny from other clinicians who are peers. The system as it stands probably would not have produced a consistency in the approach to implementation of the Welsh contract and guidance on job planning. We already see significant differences from division to division on the way the rules are interpreted, so we felt that that was something we really needed to address. And the current system is largely paper-based, which means that it doesn't give us a sort of nimble corporate oversight to look at the way in which the money we spend on medical staff is being spent. And that is something that we really need if we're going to grow and develop as an organisation in the future. So to achieve those aims for job planning in the future, we've progressed very well with a number of things which are sort of set out in this paper. And I should say that we've received very helpful scrutiny from both the executive team, the People and Culture Committee, the Remuneration Committee and the Audit Risk and Assurance Committee, all of whom have had updates on job planning. So we have written a procedure to sit alongside the Welsh contract that sets out the ABUHB way of doing job planning and implementing it. And that's been welcomed by the divisions for that clarity it brings and hopefully the consistency it will bring to job planning. And that is complete and is sitting with the BMA for their comments at the moment, and we'll make revisions following their feedback. And we've also set up a group which in the future will provide a forum for divisions to go to if changes are needed to processes so that we don't end up with siloed differences in the way in which things are done. The only way in which we can deliver job planning at scale with the frequency we need to is through an e-system. We brought together a very large group of clinicians to get feedback from end users about how they would like to use job planning software, and that included both the doctors who'd be inputting information, but also the HR professionals and the managers who will be receiving outputs from the job planning software. The initial tender specification went out and the procurement exercise failed. We didn't get sufficient interest, but colleague Simon Lyons was brought in to work with other colleagues to put the procurement back on track and manage the project, and that's been very successful. And the latest procurement exercise is set to end this month. We've had a huge amount of interest, so I'm now confident that we're going to be able to identify a commercial partner who will help us deliver on our ambitions. And in fact, as a shout out to the great work the team's doing, one of the commercial companies put in a blog, and it was anonymous, but it was clear it was us they were talking about, that the consultation that was undertaken by the Simon and the HR team around why the original procurement was failed was one of the best examples of industry engagement that they've seen in public service, which I thought was brilliant. So notes have just decided to switch themselves off in an opportune moment. So our implementation plan is still on track, but because of the complexity and the detail that's required, full implementation won't be in place until Q1 2024, by which time I hope we'll see a significant improvement that will then be sustained in job planning for medical staff. So I'm happy to take any questions.
Thank you, James. Are there any questions to James? Paul?
So I think it's incredibly important that this model is refreshed and remodelled, and that it's fit for purpose, and that there's a consistent and standardised approach. Equally, I think for members of staff, that there's a simple system which is easy to access and is for a purpose, as opposed to having to be done for the sake of it. So I think if you bring in all that in holistically, I mean, I applaud what's been proposed. I think it's an eminently sensible plan within the time frame. I know that the HR department has done, excellent work as well. So I think that it is really important for the executive team to know that this has the full support of the board, because it's politically, small p, there are potential some issues, and we need to make it absolutely clear this is the way we see the situation going forward, and we want a system in place which meets the needs of the of 2023, 2024, and is not a historical model, but actually will make a difference and will be supportive of staff, as opposed to, well, we've got to fill it in, it doesn't get filled in, and then things are not accurately recorded. And we've got to have accurate records for all sorts of reasons, and to be able to be supportive of our staff, particularly through, CPD, etc., to make sure there's development opportunities also. So I applaud the paper. I think it's really good work that's been completed there. Well done.
Sarah?
Just to add, in terms of the work we're undertaking in procuring and implementing the systems, there are national conversations around medical e-systems, but just to give assurance that we are linking in with colleagues who are taking those solutions forward. I think it's fair to say we're further ahead than maybe the national programme, but we're making sure to keep connected so that we benefit from what their progress will be, but also that they benefit from our progress as well.
Thank you. Any further, Pippa?
It's just there's a huge amount of work in this, and it's a really important thing. My request would be to have some early evaluation of it to make sure that things are on track. And it's probably best for that to go through People and Culture Committee, but rather than us sort of waiting a year to see whether or not it's been successful, I think a sort of evaluation at 3 months or something to allow changes to be made if necessary would be really important.
David?
So we're sort of following on from that. One of the things I'm quite pleased at is that the plan is to roll this out slowly, not across everybody at once, but sort of group by group, which gives us the opportunity to evaluate how well it's working in each area, potentially iron advocating.
I can't underestimate how complex the implementation will be, because if you think about an individual clinical team, we're going to want them to change the culture around their job planning, of rather than being an individual private conversation, it becomes a team conversation. So you're going to have to change culture, you're going to have to change the process to allow the team to come together to have that discussion, and you're going to have to teach people to use the way, which never goes well. So that's why the rollout has to be slow, and that's why we've actually appointed and we are training a team who are both project managers who will then segue into being the implementers, because they're literally going to have to go down and sit with the several hundred staff, and the health board are going to have to interact with this one-to-one, quite a bespoke bit of work.
One of the things I'd be quite keen to see, possibly via the People and Culture Committee, is how is that rollout proceeding?
Yeah.
How well is it working? Is the software doing what we're expecting it to do? I'd be keen to understand as well, like what's our plan for if it's not achieving the aims that we're after? What are our options? How can we make sure that we don't end up continuing to throw money at something that's necessarily giving us what we want?
Yeah.
And so on. So I'd like to talk about how we can do that along the way, because this is a really important rollout to make sure we get it right, and we can improve it before we get a year down the line and we don't have necessarily what we want. The other question I then had to add into the mix is around sort of the cost of that rollout and that implementation. I don't think that was listed in the capital plan we saw earlier on. So just want to make sure that we know how much it's going to end up costing to roll out, and we are prepared for it.
So the overall cost is not yet clear, because there is huge variation from company to company on the amount they charge, and also the amount that they charge will depend a little bit on whether other health boards in Wales choose to procure. There is one very large company in the market who have already said that if there was an all-Wales solution, the price would be different. But you are looking at somewhere between 700,000 and £1 million over the lifetime of the contract. So it is a significant amount of money. But then we spend a significant amount on medical payroll and have a limited ability to interrogate how that's being spent.
Well, you will keep us up to date about that. So we're happy with this report. Thank you very much, James. It's really, really important that we do this, because we cannot see how on earth we plan specialty services at all unless we know exactly what everybody is doing, and that it's focused on the areas of greatest need for patients.
Yeah, and if we can make it work to its full effect, which is the aim, once all of the teams have put in their plan for the year ahead, there are modules within some of the software packages that then allow you to go in a year ahead and identify where the gaps are in your services, which will then allow us a much more flexible, more on the front foot approach to plugging those gaps to make sure patients get what they need. So it really is incrementally so different from what we're doing at the moment, which is the benefit and the challenge.
Yes. Thank you very much.
Chair, can we turn the question around with the providers? Use us as an exemplar to get into Wales,
so
rather than you've tried it.
So always. So, we may well, the Welsh contract. So most of the software is being developed in England. Obviously, the Welsh contract is different. So part of our tender is that the company is going to have to rewrite bits of their software for Wales. And if there needs to be any piloting, we will, of course, be happy to do that at zero cost for us. So roll that elsewhere. And David was very helpful when he came onto the board and talking to me about your own research interest, which is looking at the way in which people interact with software. So that is something that we did sort of build in at the beginning with our groups and also with our evaluation of the programme. It's about whether the humans who will use the software can actually use it.
Thank you. Now, that was an important point. Shall we break until 25 to 12, please? welcome back. Could we move please to 4.3, the performance overview.
Yeah. So this report just gives an interim report on where we are with our performance. So as you know, we're trying to move to more outcome-based approach to our reporting, and on a quarterly basis, bring you that broader flavour of where we are as an organisation against our integrated medium-term plan and around the measures of performance indicators. In an ideal world, we'd be bringing that report to this board in January, but we don't get the validated information until sort of months, day 15, 16 in the month, so we just haven't got enough time to turn that around. Hence, we've got the interim report today. There's a few things I want to highlight in it, and a lot reflects what Nicola said in her opening reports around the real challenges that we've had through the winter period, but actually some grounds for optimism within that as well. So just a few highlights in the report, not to go through it in great detail. Hopefully there's some assurance there that we have made quite a bit of focus around our paediatric long waiters. I know that was a particular issue of concern to the and particularly those who've been waiting over a year for an outpatient in ENT services. We have actually been able to eliminate those over a few weeks now in that particular area. And we know that's a real, a year in the life of a teenager waiting for an ENT is a huge amount of time. So that's good progress that we've made there. And similarly, we're making good progress in reducing the long wait, so over 36 weeks in our paediatric services. And the other thing, positive thing I think around the sort of children's agenda is that we're continuing to make progress in sort of our prevention elements and not forgetting the importance of those prevention things at times that actually in vaccinations we've made really good progress around the hexavalent and vaccine. And that's really important in the context of flu season that we've had, RSV, that we've been able to maintain that really strong performance in the high 90% of delivery, given the impact of flu and have in our system. If we look at some of the other areas there, and in particular, I wanted to focus on sort of the planned care measures and the urgent care measures. In the planned care measures, people are still waiting too long in our system. And we know that, and we know there is still a lot more work to do to improve those long waits in our system and to reduce those numbers of people who are waiting for treatments. But where we can provide some assurances that we are delivering against what we said we would deliver. So there was a particular focus around delivering against people who've been waiting 2 years for treatments and people waiting over a year for their first outpatient. And against the trajectories which we set ourselves at the start of the year, we've maintained our performance against those. And I think what can also be said as in ways of reassurance that through that difficult December period, where we have had significant urgent care pressures, we've actually maintained that trajectory of reducing the longest waiting patients for both outpatient and treatment. And we haven't seen a resurgence in those long waiting areas. So those numbers are still high and you can still see a lot of people waiting. Actually, we've delivered against the trajectory that we set ourselves at the start of the year on those areas in a broad sense. And then the devil's always in the detail in these things. We recognise that actually when you unpick around in planned care area, those that are waiting the longest, it broadly comes down to 3 specialty areas. So ENT, ophthalmology and orthopaedics, and in particular orthopaedic spines with long waiting areas. And so we've got a particular focus on those 3 areas around action plans and work there. I know we had a discussion of those at the Finance and Performance Committee earlier in the month on those 3 areas in particular. And it's important to recognise that actually in the majority of our specialties beyond those, we've actually eliminated those longest waiting patients already and made that progress, which is positive. We've then got the section on urgent care in the paper. And again, this really does reflect the pressures that we've seen over the winter period. And that real peak in demand and pressure on our services, in particular the last 2 weeks in December, aligned with the peaks in flu and other respiratory viruses, both having that compounding impact of staff sickness and illness in our population coming in. So we did see the length of stay of people waiting in our emergency departments go up to its highest level ever. And we saw some long waiting ambulance periods in that time as well. But I think as Nicola touched on in her opening remarks, actually a lot of the actions that we took in that period around the efforts of our staff in being adaptable and finding ways in looking at opportunities that we had around making compromised risk-based decisions, really around boarding patients earlier. So that's putting extra patients on wards. That is about using our spaces in different ways, making some different and flexible decisions around discharge. We were able to maintain the best performance we could in that period, but there's still lots that we can learn from in that area. And we set up in the paper some of the actions that we're taking through our urgent care programme now to take that learning on and try and further improve that urgent care positions. I think the last thing I'd really just highlight is, particularly again for that older adult cohort, that the challenges around long lengths of stay and discharge within our system, and that's discharge from the hospital part of the system. I think that reflects the challenges more widely in social care and other areas, and in domiciliary care. And as Nicola mentioned earlier, we've got a renewed focus in that area, with Jenny doing some work around discharge. And that was partly as well in response to the correspondence from Welsh Government asking us to push further and harder on those sort of discharge elements in a wider way. So that was broadly the quick overview of the question.
Thank you, Chris. Very clear. Questions, please.
Nick? Yeah, I just wanted to add something that I picked up this week actually around planned care and the continued efforts of the team to try to address the 52-week, 104-week. And when you look at an organisational level, as Chris said, some specialties have made some significant progress. So we know some of our surgical, orthopaedics, ENT and ophthalmology are three of our most challenging areas that are working hard. But the medicine division, when Chris, I was kind of been focusing on RTT. In April 2021, they had 11,000 people waiting more than 52 weeks for an outpatient. And obviously with the backlog and continued growth, they got that down to 0 by the end of December. So there's nobody in our medical specialties waiting more than 52 weeks for an outpatient, which will include things like cardiology, neurology, gastroenterology. And that is, and as much as I know everyone is working extremely hard to that focus they put into that, I just thought it was worth just highlighting because it can sometimes be unseen in amongst the complexities of an overarching position.
Well, thank you for that, Nick. I think that is a really stupendous performance and an improvement. So do give the teams our congratulations for the improvements that they've managed to effect. Any further questions? Phil and then Pippa.
Yeah, just one or two queries. The first one is around the paediatric issues, and particularly with reference to the last time we had a presentation on WISC, they were talking about lots of difficulties with our providers. It's a really outstanding waiting times that people have to go through. I just wonder whether that is still the case or whether we've been able to solve some of that. And then moving towards the back end of the report in terms of the discharge issues. I think it's a bit concerning that we don't really know how many people we've got in a delayed transfer capacity. We've got quite wide ranges in terms of number there. I don't quite know what we do about that, but it's very difficult to plan at times when you don't really know what you're playing with. And it's the other issue around discharge for me is that it's good to hear that we are now going to have a renewed emphasis on discharge. But I think one of the dangers of that is that we normally end up by adding more to the kind of push of pushing people around the hospital. And I think what we need to look at is discharge from building the community up. So we build the pathway inward instead of trying to push people out. What most of our initiatives have been about over the last year or so has really been adding to the push, isn't it? So we have more people to discharge people, we have discharge to assess, we have all of those things which push people out. And really what we need to do is build in the community. So the community is pulling people out and indeed stopping people going in. So whilst I welcome the initiatives around discharge, I just think that we need to build it from a different perspective if we're going to have a different type of service.
I think that certainly accords with the wishes of ourselves and the Minister. And that is on which we will be concentrating within the next 6 months. It's really important.
I can give an update on this, but I think if Jenny kind of gives some of her reflections, I think when you're so whilst there's a much bigger, there's some things that are in our control, some things are much more in partnership. And I think because of your reflections are, we have built up quite a lot of complexity in some of our discharge, and one part of this problem we're trying to simplify.
Yeah,
It's a very complex pitch, so I just asked Jenny to perhaps share some of the work she's leading, and I'm
So the work we've been doing over the last few weeks has really been trying to take a forensic look, and Chris and I are doing this work together to take a forensic look at the lists, what the lists are telling us in terms of what is within the gift of the health board and our services versus what is in the gift of the local authority. And there remains a significant proportion of patients in that delayed list who we could do something about. And it's making sure that we're able to check and challenge that a lot of the time. I think there's a cultural change needed in terms of assumptions around what can be done in the home, what someone can do with at home. Because if you're an acute physician or an acute nurse who's never worked in the community, you aren't aware of the level of risk that can be taken. I think the other bit for me is how do we build up the services in the community to make sure that people can go home as early as possible? So don't leave them in hospital waiting for their 4 times a day package of care. Let's discharge them, risk assess them at home, where in their normal environment, and provide those wraparound services that enable them to be safe. And our level of safety is different to, I think, to a patient and their families. We've had active cases where families have been begging to take their relative home, but we've said no. And I think it's really challenging some of that decision making about saying, why are we saying that? Why is that not okay? But one of the things we've been doing with Chris is to look at certainly our Home First team. Is there a way to bolster that to enable us to discharge people without care to their home environment, but to do a proper assessment and to make sure that they've got the care they need? But I think the first thing is to get underneath the data. We've got a pilot that's starting on Monday at Royal Gwent, looking at a proactive approach to discharge. So working really closely with the wards, their families and the clinicians to say, how soon can we get you home? Because it's a safer place to be. It's probably a more realistic assessment of your ability and actually keep there. And there's lots of front door initiatives. I've got a view that we have, that there is more we can do to keep people well at home, to make sure that we are preventing admission and seeing those people in the home environment. And again, a lot of that links into the work Chris is doing with his teams around redesigning services for older people, but also looking at how do we work with WASC. So if we feel that there may be opportunities to leave more patients at home, what is needed in that home environment or that community setting to facilitate that? So I think it's all part of the pathway, Phil, and I think it's that forensic proper look at along all of those opportunity points.
Yeah, I mean, all that is great stuff, I think. For me, I think what would flip it is if the emphasis could be on the community. So the community, if you get admission of an older person into hospital, the community should be following that individual into the hospital, and they're after trying to pull them out. Whereas what our emphasis has been on today is trying for as much effort as possible to getting people out where they're in,
and that's
from a hospital perspective. And once somebody's in a hospital, hospitals are so risk averse, aren't they?
Yeah,
by their very nature, that they have to cover every single base before they can get somebody out.
And that's the premise of the Gwent pilot. It isn't hospital staff assessing those patients and pulling them. It's a team of social care, community staff, our discharge teams actually actively working to pull them back out. So it's not a decision we're taking in the hospital. I mean, it is a decision because they have to be medically fit, but it's really our teams challenging that and pulling them back out to the community. Where, most of these patients will be known to their district nurse, they'll be known to their community rehab team, they'll be known to primary care, and actually they're much safer in the community.
Yeah, well, I mean, I think a real micro kind of granular look at what is going on in the community, a real dividend.
Yes, absolutely.
I think if we were to look at, well, what's the level of community services? What's the level of district nursing within the community? What's the level of third secondary? What are primary care services like to do? If we look at all of those together in a granular way, I think what we would see then is where those services are not working very well, you get more in where they are, it could be more people out and the delayed transfers are less.
I completely agree. As a former district nurse, I
absolutely
with you.
Yeah. And the whole idea then about how district nurses work with community services like domiciliary care. I mean, why we still have separate teams for that is beyond me. they're the kind of game changers, I think, that will make the difference. But I was looking the other day at what the Regional Partnership Board has spent its money on in terms of discharge. And what we've actually done is put a lot more money into secondary care and not very much more into community care, because we've invested in trying to get people out of hospital instead of saying, well, actually, we need to look at this. The money needs to be in the community, it needs to be the other way around. But we've done it because we've had to hopefully this kind of looking
And I think
change.
that workshop.
Yeah.
That we're going to have.
I think it's really important, this issue, and it affects all of us, and how the whole system can operate really well for the individual. So it'd be helpful to have a report to our next meeting, both on the frailty service work that James has been leading and on the discharge work that Jenny is leading, please, because this is a critically fundamental look at exactly what we can do differently to improve patients' outcomes. Is that all right?
Yeah, very happy to.
Chris?
Yeah, just to add on really. So I absolutely agree with you, Phil, and I think Jenny's absolutely right, isn't it? It's about what is the work that we need to do internally within the health board to improve our pathways and processes. Absolutely. But then in addition to that, is what do we need to do to develop and enhance that community capacity? Yes. And I'm really hopeful that the session that we've agreed through the RPB into that workshop is a real opportunity for us to learn about innovative practice that really supports us to address some of the real challenges within our community settings. So one of the things we're trying to do is, for example, is one of the services in Bath, which is a very innovative way of trying to deliver domiciliary care by the health service and the local authority working together. So I think I want to showcase some of those things for us within the RPB to spark some ideas, to spark some things that we can do things differently to address some of the massive challenges we've got in our community settings.
Yeah. So report to the next meeting, please,
Yes.
and we'll report back the workshop anyway, formally to our next meeting. Pepper.
Yes, it's, and I guess it's probably vaguely linked in terms of, I was looking at the figures on stroke care and how we can improve outcomes for this particular cohort of patients. And I think many people who have stroke are in hospital for quite a long time. And so it would, you know, if we can do the right therapy and actually get them to where they need to be earlier, then hopefully we will get them back into the community quicker. So it's very much linked, I think, to the conversation that we just had. But for me, there's something about how are we going to improve our stroke figures, because it's really important for people, and I feel, you know, we've just got a small paragraph here, and I wonder if we can have a bit more focus on stroke and how can we get people directly to where they need to go to rather than waiting in ED, for example.
Yeah, so Peter might want to come in. So in terms of stroke, well, this week I feel like I've talked a lot about stroke, which is good. So there's a national stroke programme that we had an update from this week. Mark Hackett from Swansea Bay is the chief executive lead, and one of the consultants from Cardiff, Shaquille, has been leading that, and really good piece of work, looking right across the pathway. Fits very much with kind of our own plans and our model. And we've also, Peter is obviously overseeing that. We've also had a GIRF report. We're really clear about where our opportunities are around improving, you know, access to very rapid stroke treatment, but then also stroke rehabilitation, and then how that follows on into the community. So I don't know, Peter, if you want to just mention that, but I think this is a key priority area for us going into the review. I think it really would be useful to have a board session on it at some point where we can share some of that national work, the GIRF report, and our own kind of ambitions for this going forward, because the value case around it, you know, let alone patient quality, experience, quality of life is huge, and the value case for investing in the right place on this is significant. So I think it's a real opportunity for us.
Quality of life for the whole family as well. That's the thing. Is, you know, the patient at the centre of it, but then depending on how much they can recover, there's an impact of much wider.
And when you look at kind of the evidence of the national stroke, we are actually in quite a strong position in terms of having our centralised hyperacute stroke unit. At the Grange, it's about our thrombectomy, our access to the stroke unit, and then how we optimise stroke rehabilitation. But Peter, do you want to just say about how you can lead that piece of work as we go into next year?
Yeah, I think, as Nicola said, I think we are really focused on this in the health. We're doing an awful lot of work. We engaged with GIRF, who are an organisation who worked extensively in England, and the point of doing that is to really learn from those parts of England that are doing it really well. And there are some really good examples, and that's been important for us to identify the opportunities that we've got, and there are loads of opportunities for improvement. But then tying that together with the All Wales work through the stroke programme is also key. And I think what that tells us is in Wales, we are clearly focused on this in the right way. We're looking at the right things. There's a huge amount of work to do. I always remind people that stroke is an emergency care pathway, and like all the other emergency care pathways, it is struggling in the context of the pressures and all that kind of thing. But I would also agree with you, Pippa, that in terms of a stroke patient, their outcome and what that means for them and their family, time is everything. Time is probably the most critical factor for a stroke patient. So making sure that in the community and people get, experience symptoms, get to hospital in time. So we've got some public awareness raising work to do there, but also making sure we work with WAST so we can convey people on time when they arrive at a hospital, that we can get them treatment on time, but also then we move them through that care pathway in a timely way and they get the right care at the right time. And we often have a debate in stroke about care closer to home and those kind of things, but as a health board, we are becoming a lot better at articulating what is a highly specialist stroke input that has to happen in our centralised centres of excellence, which we are really proud of in Aneurin Bevan that we've created at the Grange. But also my argument is that if we can get that right, we can actually get people home sooner. And it's that rehabilitation at home, back with their families, where care closer to home really starts happening in a meaningful way. And one of the big impacts for a stroke survivor is the psychological impact. And getting back home with your family makes the biggest difference, really, to your recovery. So we're really focused on that as the end goal, of getting people home. It's easy to get distracted by the hospital care, which is really super important, of course, and can be life-changing for the individuals if we get that right. But also equally, we've got to get people back home and recovering and living good lives after a stroke is really important. So we're looking at the whole pathway, end to end. I just think we're in a really good place. There's a long way to go though, and a lot of work to do. And I could talk for ages about this, so I would happily come and do a more detailed session for the board on this.
Good, thanks ever so much for raising this, Pippa. It's really fundamental. And yes, we will have a board briefing session in about 2 months. So prepare yourself, get started, because it's vitally important. Improve the services and use our facilities and staff, very expert staff, in the best way possible for populations. Is that all right?
Yeah, just one small point, so obviously just a detailed point in terms of some of the data we're reporting in the board paper around performance. We have had a data capture issue recently, which we are actively addressing, and we are recruiting colleagues to support data capture and reporting. So we have got plans to address that, but we've been very open and transparent with the delivery unit in terms of our performance reporting and some of the data gaps we've got. So I guess my point of saying that is, please read the performance data with a bit of a health warning. I believe in this period we've been underreporting, and our performances are probably actually better than this. So, but we're addressing that.
Thank you, Peter. Louise?
Yeah, could we have some assurance we're going to do some work around the actual rehabilitation space within inside the hospital setting, because that's been hit and miss in the past, and obviously that does hinder people actually being discharged.
Yeah. So one of the key recommendations from the report is around our rehabilitation provision, our hospital-based rehabilitation provision, which we currently provide in three places: Neville Hall, Royal Gwent and YYF. I had a walk around Neville Hall just a couple of weeks ago, met the stroke team and spoke with them, and I could see that they just don't have the space on that ward for just active rehabilitation, just rehabilitating the patients. So as a result, they have to do it at the bedside and that kind of thing. So I recognise that, and that is clearly something that we must address and get right. Rehabilitation space for the allied health professions to do that active rehab is going to be key to getting people home as soon as possible. Completely see it, Louise. And the direction of travel for us is to look at those 3 rehab sites in the health board and understand, prove that arrangement that we've got for subacute stroke rehab, and really kind of address that. So that's one of our major planks of work in the.
I think sometimes people think that it doesn't happen from day one. On the acute setting for the rehabilitation for start and the treatment for start, which it does.
So, I mean, you talk to any stroke consultant, they'll tell you that in terms of the clinical input that a stroke patient has, 80% of it is therapy. Yes, that much. That's that important. So.
Yeah. Okay. So yeah, I just feel maybe we're missing a trick here by not actually making sure that we've got the whole of the service adequately funded and participating basis to do rehab.
So we will bear that in mind when challenging the report.
Thank you.
Get it in a couple of months. Nicola, what about the paediatric surgery specialist?
Yeah, so just going back, so I know WISC we're looking at, because the activity levels within Carbon Vale are maintained themselves, they've not been able to improve that, and that's something that's being looked at through into next year as to, what's their ability to deliver, so that they can make decisions whether that's elsewhere. I know they have been looking to secure an additional activity outside of Cardiff. As of the latest reporting period of month 7, from an outpatient's perspective, there was nobody waiting more than 36 weeks. There was a small number between 26 to 35, but the majority of paediatric new outpatient were waiting less than 6 weeks. The inpatient one is more concerning, where there were 8 patients, and I don't know how many of those are. There were 8 patients that were waiting more than 2 years for their treatment, but they were intending that all of those would be treated by the end of March. But there's still quite a high number who are waiting more than 52 weeks for their, looking at the number, I would guess it's around 100 children who will be waiting 52 weeks for their inpatient treatment. And that's where the focus will need to be, understanding what Cardiff can deliver next year and what the constraints are, and if not, whether there's commissioning options outside of them. And obviously, if you then look at Alderhay, which serves the north, they are in a much more positive position. So that can equity for the rates as an issue. So I can give a more update report as at the March meeting.
Thank you.
But that's the data.
Yeah, I do think that it's not acceptable for specialist children to be waiting for that sort of period of time. And we must urge WISC to look again at how they can secure a better contract with better outcomes in terms of time to wait.
But also how delays are escalated in the system.
Right.
It should be something that happens
exactly
prospectively, not through chasing.
No, exactly. So what we will write a joint letter.
I obviously have fed back to the WISC Joint Committee.
Yes.
The discussion we had to this board and the importance of putting on children's services and the impact the children have on their longer term development. So
yeah, thank you. Are there any further questions about the performance report? No? Okay, thank you. Thank you, Chris. Could we move then to please the finance performance report, Rob?
So the report in the pack is the financial performance report for the 9-month period ending December 22. The dashboard on the first page identifies the revenue position of a year-to-date deficit of 31.8 million and a forecast of 37 million deficit, and they're in line with our revised plan submitted to Welsh Government following the mid-year review. Capital is online to spend and break even. And our public sector payment policy performance, which is our paying invoices within 30 days, is above the 95% target. In addition to that, our cash position is in line with best practice levels as well. In terms of key points, we've got some positives to report in terms of the month 9 year-to-date position, as I mentioned, is in line with our revised profile. 31.8 million, so that's a positive thing for us, even though it is a deficit. In terms of income, we do continue to assume COVID and exceptional cost funding to the rest of the year of approximately £32 million, and that's the energy cost really, as the exceptional piece there. Pay has reduced by just over £1 million, and variable pay is reduced as well, so that's very positive. We do continue to have high levels of variable pay, as I'm sure won't be a surprise there, but again, positive move for the period. In terms of non-pay, we have seen some spikes in the month in terms of expenditure, but they are funded and they were planned to be spent. So again, that £5 million move is funded and isn't adding to the deficit. In terms of savings, again, a positive position. The new savings plans that were implemented following mid-year review ahead of profile by just over £2 million. Although we do have risks to make sure, mitigate and deliver against to make sure we get the full level to achieve our £37 million. So there's something to note. But a positive position for month 9. And I do appreciate that's a rare thing for me to be saying this year. So I think that's quite good. In terms of the forecast, we are holding a forecast position at £37 million deficit. As I say, we've got savings programs re-established, and we are reporting 5 million of those remain at amber. There are actions progressing, but and I'll come on to it in a moment, there are operational factors we're experiencing with winter, ongoing urgent care pressures, the industrial action occasions that we've had to deal with are offsetting some of our beneficial impacts. So we do need to make sure we're delivering or finding alternatives to manage to the year end. In terms of our underlying position, we have moved that adversely as part of our report in the Welsh Government for months 9 and in board today to a figure of £52 million deficit. Now, in previous sessions we've held in the Finance Performance Committee, there has been analysis done of what that may look like come the year end as a forecast, and we're going to continue to work on that as part of our IMTP process. But there's a very real and significant risk of that being a higher figure, depending on what happens with the final funding arrangements for next year and actions we take, decisions we make as part of the IMTP. In terms of operational factors, we've talked about this already in terms of the pressures on performance and the systems we're operating within. Say overall pay did reduce in months, and variable pay, although remains high, did reduce as well. So again, that's very positive, and it was the lowest level of variable pay for 13 months. So again, that's good news. The challenge will be maintaining that, and just to be aware, it was a 4-week month, and it was over Christmas, which is an anomaly in terms of, so you can appreciate how normal weather is, but just to be aware of that. We continue to operate with over 150 surge beds and temperature capacity established to deal with COVID patients, delayed transfers of care issues, and again, they remain consistently high. Again, we've had this conversation just now, so I won't repeat all the issues around that. And enhanced care remains high. It is starting to fall in month, but again, if I pick the Grange has still got 32% of patients receiving enhanced care. So the acuity of the patients we're seeing continues to be very high. Energy costs, whilst being funded this year, they have dropped slightly, but it remains volatile, and our current costs estimates for the year is approximately £30 million. As I say, there's non-recurrent support this year, and we've been advised that won't be available next year, and that's part of the elements and parameters driving the underlying position. CHC places have dropped by 33, which is a lot for a single month. So that's whilst a sad story, is actually having a financial benefit to a position. Of note, though, is the volatility we've experienced around prescribing and prescribed drugs, and that's moved through significant pricing changes, what we call the NCSO categories, no cheaper stock available, basically limited stocks available of certain drugs. Reported previously how that cohort of drugs has increased and continues to operate at around 200 drugs. And that's potentially having a full year impact of in excess of £1 million. But we do refresh that estimate every month as and when information becomes available from the National Information Centre. Elective activity continues to be delivered, and again, that's been picked up in Chris's report. Savings analysis is presented in the report. As I say, we're in advance of our profile for delivering our savings programme, but we do still need to make sure we're going to achieve the full delivery around all the elements we've described. Risks identified, most of them are consistently reported from before. As I say, prescribing is probably the newest element of our risks that's worth keeping an eye on, and obviously we are looking at that consistently and constantly. And just in terms of the board is asked to note the report assurance.
Thank you, Rob. Are there any questions? Jeremy?
Just one question around the enhanced care. And I understand obviously from financial, that we're obviously still spending substantial sums of money on that. But it is coming down, I can see that. So my question is that's a financial perspective, but are we satisfied that the improved outcomes we get from providing that enhanced care are actually coming to fruition? So, you know, talk about sort of reduced falls and what have you, which I think we have got evidence. I just wonder, well, have we got an evaluation of that? Because it does seem to be a lot of spending, you know, across the board now as well, and particularly, for example, in GP. But maybe because the patients are sicker, they might need the help, but then in the community hospitals as well. So I just wondered, have you got any evidence on that?
So there was an exercise done last, I think it was last summer. Somebody from my team and the nursing team to look at a few wards, and it was difficult to show cause and effect with the information we had available, but broadly it did show a positive impact in comparison with wards there where there wasn't enhanced care. The difficulty is those wards potentially had less acute patients. I don't know if Jenny wants to, but we possibly could do another exercise. Update that.
I suppose my issue is that these patients, I know people are sick and coming into hospital, but they've been treated when they're in hospital. This just seems to be a huge increase and more of a go-to type of arrangement. I don't know whether the criteria have changed, so more people are now come within the criteria where enhanced care. It might be that it's absolutely, I'm not suggesting we don't do it, but it has exponentially improved, certainly in the last couple of years. It's gone up and up and up, accepting it's coming down.
There's no doubt the acuity of the patients has increased, and we are seeing more patients who are unwell and sick with comorbidities, of which, you know, acute confusion and dementia, are often commonplace. I think it hasn't been reviewed since I've been in post, obviously, and I think it would be good and timely to do a review at some point, mainly because I think because of the work we're doing in terms of discharge, in terms of some of the work that's ongoing on the wards around managing patients with dementia differently, so looking at meaningful activities, looking at turning spend into volunteer to career roles in terms of recreational support for patients who are on the ward. I think it is probably time to do a review this year and to really think about are the interventions we're doing, are they the right ones, or should we be looking to do something different? Because I think there's a difference between somebody sitting and watching somebody who has dementia and enhanced needs versus somebody who is interacting positively with them. And there are some examples from Swansea Bay, for example, where they've really looked at how you enhance activities for those people, and they've had some pleasing outcomes. So Sue Pearce, for example, has been down to Swansea to take a look. So I think it's probably timely for us to have a look to see actually is what we're doing the most effective intervention? I think in some cases, yes, probably some cases, no.
Okay, so we'll adopt that. Thank you, Jenny. Paul?
I'm just looking at the list of its significant risks really, and just asking Rob, what could the board do to help and support you with regard to the financial position for next year? And also, is there any mood music currently about what's going to happen about the potential deficits that all health boards will be having? I understand that all health boards will have deficits, and so two parts there. What can we do to help, and what's the mood music on where we are likely to be on April 1st?
So a lot of the risks are just reflective of the current operational situation that we're operating within, and the potential financial impacts on that may have an impact on how we're forecasting the financial impact at the end of the year we're identifying. In terms of help from the board, I think at this point it's just to be aware of them and the volatility of if certain things change. So if, for example, Welsh Government don't choose or are able to support some of our COVID expenditure, then that will have an impact on our bottom line, through to the uncertainty around our continued urgent care pressures, continuing to have to open surge beds. To a large degree, our forecasts represent the best intelligence we have now. But if there was, say, further industrial action more than we're aware of now, then that would have an impact. So it's really the list is predominantly for awareness of the board. I think probably where we are, we may need to have a wider discussion with the board on risks, is whether we can mitigate our savings that are amber, or we might have to do certain things or make certain decisions to improve our financial position as we get closer to the year end, when we're probably in extremis in terms of trying to hit the target that we've agreed with Welsh Government. So that's the one piece. In terms of the mood music of financial positions, and at month 9, all health boards are in deficit, reporting a deficit for this year other than Swansea Bay. And informally, from a conversation with the All Wales Finance Directors peer group, that's likely to be worse for next year, with underlying positions emerging a lot higher because of the situations we're continuing to operate and the reduction in the COVID and other secondary funding that we've received this year.
So with regard to our IMTP, have we got costings associated with each of the areas? So when the plan is developed, have we got budget headings? So it's quite crystal clear as to what each of the budgets are, and when it comes to them to be reviewed or monitored, we can say, well, let's look at that. Because I think sometimes the plan we see is full, but sometimes doesn't have the costings. Will next year's plan have those costings on the plan?
Yeah, like we do every year, there'll be an analysis of how our costs are going to move, decisions that have been made, or rollover costs that we're unable to mitigate. So that process has started. We're obviously in the middle of forming our IMTP, so workforce service performance factors build in and have an impact on our financial position and plans. So that's all in progress.
I mean, some really good stuff on the payer piece to be, that reducing on some of the areas there, which I've sort of picked up on as well. Volatility of the prescribed drug costs, is that because some of the drug companies are now reviewing their sort of position with regard to their funds and contracts and things? Because that just seems to be that seems to have gone up quite a lot.
So that's a very complex arrangement in terms of how drug companies get paid in terms of their income for what they produce and supply the NHS. So it's an all UK-wide arrangement that sets the income and the profit margins for drug companies contracting with the NHS across the UK. As stocks of, so the NCSO comment I've made is, as stocks of drugs are dwindling, either through there may be a run on, like we had a run on antibiotics for children recently, they effectively can move the categories of drugs into this limited stock arrangement, and that they can charge more for that because it generates more income and profit for them to hit their target. It's very, very complicated. I can talk to you about it again, but it's predominantly a pricing issue for us. That's the risk that's emerging. We also have got the confusion or confounding factor on the ability to move from a month to 2 months prescribing, and we're trying to make sure that our forecasts are based on the best intelligence we can to allow for that. And again, a confounding factor around that is whilst we might be seeing 2 months or doubling up about prescribing volumes, not every practice is doing it, so it's not an automatic switch. So that's a bit of background work that's going on now to try and work through whether our forecasts are appropriately set. But from the work we've found, we're quietly confident with the numbers we're using, and then have established based on the data we've got available. They're agreed with our pharmacy team for reasonableness. But if that NCSO category keeps growing, then that's a significant risk for us, because we even had as an example of there's a category of drugs called CAP-M, which is generally our sort of more generic, this is a basic explanation, but a more generic pot of drugs that in the past have been, once drugs have moved into that category, they're usually a lower cost, not always, but usually. We've had the anomaly of some drugs going from open market rate to a CAP-M category because of supply jumping into NCSO. So it's gone from a reasonable price to a lower price to a premium price. So it really is volatile.
That's my worry, really.
Any further questions?
Thank you.
Thank you. Just one thing from me. On your savings report, you state that you're going to eliminate unwarranted clinical variation to deliver improved efficiency and to reduce waste. Perhaps we can have a note on how that is going to be achieved. Be helpful.
Yeah, sure.
Thank you. Any further comments?
Well done.
Shirley, it's a point of clarification, not particularly for today, but again, in that savings section, it talks about we have to intend of these priority areas for the program management team, obviously led by executives and value health. These now need to be accelerated for sustainable solutions and long-term financial recovery. I mean, I know we've discussed lots of this, but I wondered if we could just have a note about what those 10 priority areas were. Again, we've got so many priority areas. Just
yeah, deal with the IMTP.
On the end.
Yeah.
I think that would be useful because we've got a few newer members.
Yeah.
So just headlines, that'd be great.
I think the issue around that is whether they continue to be priorities for the new year.
Yeah.
At the moment, we're assuming they will be. But again, in the round situation within, they need to be refreshed.
Thank you. Thank you very much. Can we move to 4.5, the strategic risk report, please?
Yeah, thank you. So this is the standard strategic risk report. The breakdown of the risks summarised where 32 organisational risks, 23 of those categorised as high, most of which we will be familiar with from the support documentation as well. Just to pull out a couple of points, I think it's just worth mentioning the audit of our compliance with the wellbeing of future generations and socio-economic duty for Wales is going to be picked up by the Audit Risk Committee and scheduled for the 2nd of February. Recognising we need to probably reframe some of those, but there'll be a deep dive on that particular area. There's going to be quite a focus by the executive team, which will also then bring as part of the discussion with the board around, our risk management approach and our development of a more risk management strategy, assurance strategy. So we're quite keen to. I know we constantly kind of try to refresh this, but I know Rani has got some ways in which we can improve our approach to risk management, which we will welcome that discussion with the board then once we have that deep dive as an executive team. And then I think it's just, I need to mention that we have
change the rating of the achievement of financial balance from a 16 to a 20 following and our forecast. That's all I was going to put out to as headlines.
Thank you. Are there any questions to Nicola?
Shelley, if I could just come back on the point I made earlier about the risk around the estates, and so we need to look at that again in terms of it being within its target area.
Yeah.
So if I could just request that that's done.
Yeah. Fine. Okay.
Gavin?
Just to follow similarly of the infrastructure and cybersecurity risk.
Yeah.
Related to capital.
Can I just comment on that, just to say that we are going through an approach of and taking deep dives on each risk, each executive owner, and that we're taking through to respective committees. So for those two, they would come to Finance and Force Committee to look at their scheduled.
Thank you.
Sorry, could I just ask, Anne, there was on the buildings thing, there was an interesting report on Betty Cadwallader with regard to the estates. I just wondered how we compared with, in terms of, not see how we compared, but whether or not that was useful in looking at our estates, because I mean, some of the estates, particularly historical parts, just wondered, any thoughts on that, Nicola?
I can follow that up and maybe we can just do a comparison and give a brief.
Yeah, that'd be useful, because it was, I think there were probably political reasons why they did it, because obviously you want to get some more money or anything, and you would look at it. But from our perspective, I think it may be useful just to understand what we need to do. Thanks.
Follow that up.
4.6, the Executive Committee.
Yeah, thank you. So this is a summary of the business of the Executive Committee over the last 2 months. Again, just reinforces the structure we've now put in place around our weekly Executive Committee meeting, but also around that we've got the informal sessions as well as monthly clinical futures programme board and our finance recovery and turnaround. Albeit we talk about finance every week, given where we're at. I was just going to pull out one of the information is there for people to read. Under quality and safety, I just wanted to reinforce that we've had this wider system leadership meeting, which is a follow-up tomorrow, when we're particularly talking about how we improve our flow through the system to improve our ambulance rates, which continues to be a key concern for us. So I just wanted to pull that out. And also we had a really positive session with the Continence Service recently with a research project that has got some national kind of accreditation and recognition, particularly around how we manage continence care for people with dementia. And we will look forward to sharing some of that with the board once the project is complete. But really is, goes right down to the heart of patient dignity and links very much to the patient story as well, in terms of recognising different patient groups and their needs and abilities. So really passionate individuals within the organisation about doing this work with national recognition. And then I thought it was useful to pull out the decarbonisation. We've had some specific items on the exec agenda. It is one of the 10 priority programmes. Rob is taking an executive lead. And whilst this previously is often focused on carbon emissions and the traditional energy side of things, I think what Rob is finding, there's a huge amount of passion out there in our organisation. And it really is a different way to engage with our staff. And I know, Chris, you've been actively involved in this since the outset as well. But we were one of the first organisation to change the anaesthetic. Do you want to explain a bit more about it? Because I think it's really important to pull out some of the passion of our work, particularly junior doctors on this one example, to really engage, which I think will have a huge amount of benefits beyond just the decarbonisation agenda.
Yeah, so again, just one thing. So I've been really happily and pleasantly surprised around clinicians and anaesthetists in particular wanting to get into the programme, actively engage in it, become subgroup chairs and really push the agenda, which I think is brilliant given all the other pressures that we're experiencing at the moment. So we've become the first organisation in Wales to stop using a particular drug, and I can't remember off the top of my head what it is. I'll probably quote it incorrectly, so I'm not going to quote it. That's the one. That's the one. That's the right, yeah. And we've got rid of that through our theatres, and we're looking at how we effectively do that throughout other parts of the organisation. There's other gases we're looking at around nitrous oxide usage, but also moving on to a conversation around paracetamol and the IV versus oral usage of that. So there's a lot of benefits around that in terms of all the plastics, in terms of IV kit compared to the tablet, but also then the cost reductions. So it's a win-win. That won't be 100% shift, because we've got to allow for certain exceptions, but that's something that's being considered now again by the same group, and hopefully get that rolled out and get that enthusiasm established with some wider groups. And there are conversations with theatres and other areas as well, like consumables and things like that. So really positive. And watch this space. There'll be more reports coming.
Thank you, Rob. I just thought it was worth drawing that out because it's really positive in terms of the enthusiasm from the workforce teams. And then just finally, I think picking up your point, Shelley, we'll get that update is under the Clinical Futures head. It just reminds us of the 10 priority programmes that we can update. So that's it. Thank you, Chair.
Thank you. Any further questions to Nicola?
Really good. Well done.
Thank you. The overview of joint committee activity.
Yeah, thank you, Chair. So there was a WISC meeting held in January. We've only just, since the board meetings, have had the updates on the 2 meetings before, which we can share after this meeting. So the main focus of the last meeting is very much been on the integrated commissioning plan, which is into next year in terms of what the demands are in terms of growth and cost pressures that we see through those specialist services, and how we are going to meet all those needs with a very challenging financial context. So that's very much been the basis of the discussion. WISC have obviously been doing their work that they always do with the providers and speaking to the commissioners in terms of what those priorities are, and trying to take a very realistic approach as to what we can deliver with minimal investment in terms of new things, but they're very much trying to meet the needs of previous investments decisions we've already taken, and where we've seen natural growth in services. So there'll be further work to come. There's another meeting scheduled for February where they'll be looking for health boards as part of the committee to sign that off. So we need to make sure we line up the governance in terms of our decision making as part of this recommendation. But the broad headlines at this point is around what they see as at least a 3% increase in the allocation to meet the minimum requirements. We've had further discussions to say, can we try to push that down with a further 1%, looking at opportunities that are by looking at some of the big areas of opportunities where we commission services for high cost patients in England, and can those be done in a more effective way by investing in upstream. So there's a number of areas where we think we can do more work, and maybe if we can take that down by 1%, so we're more in the 2%, that's kind of where the conversation has been led, which we'll pick up with further opportunities. That has been the main element, in addition to the normal performance reporting and other parts of the agenda. Reporting.
In terms of the governance, the existing arrangements are that the joint committee signs it off, but that could is that not right? Yes. That could in some instances mean that the board itself that then commits itself to the plan will never have seen the plan. That's terribly onerous on the shoulders of the chief executive. Mm-hmm. So how are we going to alter that governance arrangement?
So I think, that is something that comes up very much through the WISC committee, I think, in terms of recognising the WISC governance, but also how that is difficult for chief executives to sign up to a 3% uplift in financial reportings when we haven't done the choices and priorities of the rest of the organisation. And therefore, I think we will need to, I'll just need to find a way with yourselves in advance of the February meeting to seek your support around the direction of travel. Hence, I've just given some of those headlines this point. I think 2%, you know, it's important to look at investment in specialist services on a UK basis. They do often generate greater costs than other parts of the system. But I feel 2% is this, to go beyond that, we are compromising choices we are locally.
Yes.
And there is opportunities in this agenda to do things more effectively. I don't know what's the committee recognising he's.
Yes, so like, just to echo what people have said, I think there's touched on earlier around some of the under delivery of the commission services that WISC do commission. I would say particularly within the Welsh provider setting and the arrangements they have in their contracts need to be reviewed in terms of the delivery in a couple of key areas which have been reported previously, cardiac surgery, the PEDS issue, and some of the work that's gone in Swansea, because there are fixed and variable costs supported, but if we're not getting the services we need, I think there is a need to review that seriously. There will be an issue as a cross Wales issue, if you like, in terms of once for Wales, but we are closer to the border than some and can make use of that and get services elsewhere, assuming services are available elsewhere, because we have had challenges in the past around accessing services, not really when money has been a limited factor, it's their ability to do it.
I think just it is worth adding on that point that there have been quite bold assumptions in the financial plan for WISC around if performance is being delivered in terms of recovery of that. So there are some quite bold assumptions which the providers will need to respond to as part of that as well. So that has been taken on board by WISC, and is that factored into the plan, and the latest update. So I think for this health board it was about a £6 million uplift. The latest figure was around 4.5 million, so it had reduced. But I think we should look to get further efficiency out of that by another third of that, I think, to make it into a figure that is more in line probably with the allocation that we've been given.
Just Nick Larson quoted it. We just as a reminder, we got 1.5%, and that's our uplift we're supposed to pass over to our providers. So you can see it's basically twice that. And I think the other thing to note is across Wales during COVID, we've had arrangements put in with some of our contracts and long-term agreements where we're being more tolerant of variation. And as a health board, I'm advocating that those temporary arrangements, which are always intended to be temporary and end at the end of March, we go back to our standard arrangements, and that's what the WISC plan is based on. So just to make it clear to the board that we have supported providers over the last couple of years in terms of stabilising the system, but obviously going into the next year now we revert back to terms.
Yeah, just as a final point, because on WISC, because of the way it's structured, it's generally a conversation about money and about what we put it in, and it's about how we put the story behind that. And that's what will be important in terms of, okay, so the impact of not doing this, in terms of our patients accessing bone marrow transplant services, renal transplants, cardiac surgery, burn services, they are very expensive, high profile, small numbers, but hugely impactful and life-saving. So understanding what's driving that demand and what we invested in and what we're getting for it, and the impact if we don't do it is really important. And having further work for us in terms of what is the needs of our population around specialist services and those accessing services in England. Specialist mental health services is another key area. So I will try to get a greater narrative, which is out there, but often by the time when we talk at this level, it's very much about what's the benefit of all of that. But there's a very important service narrative that obviously goes on around this, the very important services for our population.
Yeah, absolutely. So we'll take this further and try and get a better analysis for the next year. Anything on these?
Just 2 points briefly. Jenny kindly attended ESC, clashed with the RPB. So Jenny attended. The 2 main points from the meeting is, one is just the continued requirement to reduce ambulance handover delays, and particularly have nobody waiting more than 4 hours. And we are, the meetings I've talked about, the system leadership is focusing on how we reduce those patients waiting more than 4 hours, in addition to total lost hours coming down. And then there's also there's an engagement exercise ongoing, particularly around changes in the EMERT system. This is the emergency retrieval transfer service. It does primarily affect other parts of Wales, but it is part of the overall service, and therefore important that we engage on as well.
Thank you. Any comments? Any questions? No. Okay. Finally, key matters from the committees of the board. We've got audit, risk and assurance, patient quality, safety and outcomes, mental health act monitoring and shared services. Are there any issues that people wish to raise on any of those, or any added information the chairs would wish to give? Yeah. Oh, Sarah.
I attend the Shared Services Committee, and just a point of note in really, because it may not be clear from the update, just to make sure everyone has on their radar. On the bottom of page 3 in a bullet point, there's reference to TRAMS, the Transforming Access to Medicines National Programme. There was a staff consultation May, June of last year, and there's likely to be further staff consultation because there are likely to be implications for our staff within that programme of work. So just to bring that point of clarity, which may not be there within the update.
Thank you. Thank you, Sarah. Any comments, questions? No? Okay. That is the end of the meeting. The date of the next meeting will be the 22nd of March, and thank you very much for your engagement today. We will now close the meeting to the public and go into our confidential agenda. And can I thank the public who have attended this morning, and hope you found it helpful to inform your views about how we do. Fantastic.